to the Department of Neurology of Chengalpattu Medical College who have come forward to present their cases. And I thank Professor Shankar Ganesh and Dr. Balaji for arranging this session. And I'm extremely grateful to Professor Vasudevan, Professor of Neurology at Savita Medical College, who has consented to be the chairperson and conduct the proceedings. I'll hand over now to Professor Vasu to conduct the proceedings. Professor Vasu, please, you can take over and conduct the proceedings, sir.
Can you hear me?
Thank you, Vasu. Yeah.
Hello, can you hear me, sir?
Yes, I am hearing you.
Thank you very much, sir, for the introduction. But there is a slight change in that, a permanent change. I am no longer at Savita.
So, I didn't know that.
That's a recent development. So anyway,
have you joined anywhere else?
Not yet.
Okay.
Not yet.
Yeah.
Thank you, sir.
Right.
Thank
Doesn't
you.
matter.
I think we'll start, sir. We'll start with the cases.
Sir. Yes, sir. Please.
Yeah. Thank you.
Thank you. Thank you.
Sir, morning, sirs.
Morning.
Yes.
Sir, good morning, sirs. Is my screen visible, sir?
Yes, please.
Yes, sir. Shall I start, sir?
Please.
Yes, sir. Good morning, sirs and ma'am. Today we'll start with the case presentation of unraveling a diagnostic challenge in an elderly female with weakness.
Please go ahead.
Sir, my slides are visible, sir?
No.
Siddharth, your slides are not yet visible.
Okay, sir.
Yes. Now
it's visible.
Okay, sir. Shall I start, sir?
Yes, please.
Okay. Good morning, sirs and ma'am. Unraveling a diagnostic challenge in an elderly female with weakness. Next. 66-year-old female homemaker, resident of Chengalpattu, right-handed individual, came with complaints of difficulty in swallowing, difficulty in speech, difficulty in using her all four limbs. For the past 7-year durations, the symptoms worsened since last 2 years. Patient was apparently normal till 7 years back. History of difficulty in swallowing, which was insidious in onset, gradually progressive, initially present for liquid foods, eventually progressed to solid foods associated with nasal regurgitation. History of difficulty in chewing food items present more for hard foods. History of difficulty in manipulating food using tongue and marshalling food bowls present. History of clogging of food in buccal gutters present. History of dryness of mouth and she needs to take water in between while taking the food is present. History of spillage of food in sides of the mouth while eating is present. History of difficulty in drinking water associated with nasal regurgitation and spillage of water in sides of the mouth is present. So she sips and drinks water slowly. History of difficulty in gargling mouth and blowing air in cheeks is present. History of slurring of speech present. History of difficulty in understanding speech by attenders associated with nasal twang of voice is present. History of drooping of eyelids, more in the left eye, not associated with diurnal variation, and there is no history of double vision. History of difficulty in closing eyes is present. History of difficulty in lifting neck of the pillow is present. She needs to keep her hands behind the neck to push her head and neck to raise from the bed. History of difficulty in turning side to side in bed and getting up from the bed is present. History of weakness of all four limbs. Difficulty is more in using both her hands and it is more in her left hand. History of weakness of both lower limbs present and it is more in getting up from squatting position and it is more in her right lower limb. History of difficulty in mixing food, holding objects and wearing sari is present. History of difficulty in combing hair and keeping or taking objects from the shelf is present. History of difficulty in insinuating foot into footwear present. She is able to grip her footwear well, and there is no history of aware or unaware slippage of footwear is present. History of difficulty in getting up from sitting position, and for the past 2 years, she needs the support of attenders to be lifted up from the sitting position in floor. Even while getting up from chair is difficult for her. She used to lean her both hands on armrest to get up from chair. Now she needs attenders' help for the same. History of difficulty in squatting and getting up from squatting position for toilet purposes. She has changed from Indian toilet type to Western toilet type for the same complaints. History of difficulty in climbing stairs, and in an initial period of her illness, for climbing stairs, she used both her hands pressing forward in staircase to climb up. Nowadays, she is not able to climb stairs. History of easy fatigability of limbs and muscle aches is present. No history of improvement of symptoms after rest or with exercise. History of flailness of limbs is present, but there is no history of twitching in muscles. History of thinning of limbs present. No history of sustained hand grip. History of loss of appetite and loss of weight is present. No history of any sensory disturbances. No history of unsteadiness while washing face in wash basin is present. No history of bladder bowel disturbances, no history of swaying while walking, no history of involuntary movements, no history of fever, seizures, behavioral or sleep disturbances. Past history, history of migraine headache is present. She used to have 1 to 2 episodes lasting for about 30 minutes per month, and it lasts for about 1 to 2 hours per 1 to 2 episodes per month. No history of previous medical illness, no history of any drug intake. Family history, no history of similar members among the family members. Summary, 66-year-old female with insidious onset, gradually progressive neurological illness of 7 years duration, worsened since 2 years, with bulbar weakness, bifacial weakness, bilateral ptosis, neck and axial muscle weakness, quadriparesis, pure motor weakness, which is more in the distal upper limbs and proximal lower limbs with some asymmetricity. So pure motor element syndrome with no sensory, bladder, bowel or any higher mental function involvement, no cerebellar or extrapyramidal involvement. Shall I proceed, sir?
Yeah, I mean, where do you localize clinically from the history?
Sir, clinically, it's a pure motor element syndrome, sir, with no sensory involvement, sir. Associated with bifacial, bifacial weakness, bilateral ptosis and bulbar symptoms, sir, with neck and axial muscle weakness, sir. So we thought in terms of neuromuscular junction, muscle and anterior horn cells, sir.
Oh, that is, I think, the easy part, isn't it?
Yes, sir.
Now, among these three, which one do you think? And is there any pattern to the weakness which has evolved over these 7 years? Consider her age.
Yes, sir. It started with bulbar symptoms, sir. Then progressed to have bifacial weakness, sir. Then she had ptosis, sir. At the same time, she had proximal weakness of lower limbs and more of distal weakness of upper limbs, sir.
So you mentioned about difficulty in what is it? Hand grip.
Yes,
so
sir.
What is that? The previous slide, the slide before that. Something
This one,
about,
sir?
yeah, no history of the next one. The next one. Something about sustained hand grip.
No, sir. No history of sustained hand grip, sir.
So what does that signify? Myotonia,
sir,
obviously.
Myotonia, sir. No history of myotonia, sir.
Okay, so when you summarized, you
Yes,
mentioned
sir.
facial weakness, but there is what else did you say? You said ptosis, right?
Yes, sir.
Said ptosis. Right, but is there any history of diplopia?
No history of double vision, sir. I mentioned, sir.
He mentioned about fatigability.
Yes,
Okay.
sir. No history of fatigability, sir, or any diurnal variation, sir.
Okay, fine. So then what is the order in which you will consider these three?
Sir, there are points favoring and against for all these things, sir. For NMJ, there is history of ptosis with bulbar and bifacial weakness, sir, with muscle weakness, sir. But there is no history of any fatigability. There is no history of any diurnal variation, sir. And there is no much of there is thinning of limbs, sir. So that is again, sir. For muscle, it is a pure motor element syndrome is in favor, sir. Wasting is there, sir. That is in favor, sir. But asymmetricity is against muscle, sir.
Why?
Sir, usually we consider symmetrical illness in muscle,
Not
sir.
necessary.
Yes, sir.
Not necessary at all.
Yes, sir. Yes, sir. Sir,
There are certain conditions where it begins with asymmetry and remains asymmetric for a long time, especially which are slowly and indolently progressing. You can have
Yes, sir.
certain dystrophies.
Yes, sir.
So
more in favor of muscle, sir.
What?
This presentation of bulbar with bifacial with quadriparesis, sir, with some asymmetricity, pure motor element with no sensory or other involvements, sir.
Okay, why not? The third thing which you mentioned is anterior onset.
Anterior onset, sir. In NMJ, we considered musk myasthenia, sir, since elderly female presenting with bulbar, bifacial, and ptosis with weakness, sir. So, whether it could be a musk weakness, we considered, sir. But other generalized myasthenia gravis, she did not have any crisis during the period of 7 years, sir.
Okay. But does that entirely go against
No,
diagnosis
sir.
of
No, sir. No, sir.
Okay.
Anterhonsel because of pure motor element syndrome with wasting
But
and
tell
weakness.
me one thing, you have a lot of wasting everywhere, isn't it? You have wasting in.
Yes, sir.
Where else you said thinning of muscles in the limbs also?
She noticed thinning of muscles in the limbs and face, sir.
So does that go in favor of neuromuscular junction disorder? Let us not go into musk and all that now. You stick to the basics now.
Okay, sir.
How often do you see so much of wasting within 7 years in a myasthenia?
No, sir. Sir?
Right.
We don't expect wasting in NMJ disorders, sir.
Yes. So where do you see the wasting? Which conditions do you see wasting?
Muscle and anterior honsel. Anterior honsel is more of wasting, sir. Then we can have wasting in muscle diseases, sir.
You can have wasting in muscle disease also. That is right. So is there any symptom vis-a-vis weakness, wasting and weakness?
Is that the wasting is not out of proportion to weakness, sir.
Okay, so what does that tell you?
Anterior honsel is less likely, sir.
Wasting is not out of proportion to the weakness.
Yes,
suppose
sir.
Okay, right. But suppose weakness were out of proportion to wasting.
We will consider anterior honsel, sir.
Think again. What are you saying? You're contradicting yourself, isn't it?
Sir, in
wasting out of proportion to weakness and weakness out of proportion to wasting.
Yes, sir. In anterior honsel disease, wasting will be more and weakness will be less, sir.
Okay, now we are still at the history, but based on history, yes, do you think there is any disproportion, weakness and wasting, or is it they going hand in hand all this time?
Almost hand in hand, sir.
Okay. Did you mention about fasciculations at any time?
Yes, sir. No history of fasciculations, sir.
At all?
Yes, sir. No history of fasciculations, sir.
Okay. Okay. Right. So now, having said all this, we are dealing with a placid, progressive, very slowly progressive.
Yes, sir.
Almost symmetric. Yes, quadriparesis with bulbar and bifacial weakness in a 66-year-old woman, isn't it? Which is pure motor.
Sir. Yes, sir.
So now you have three possibilities. Why don't you consider a fourth one? Can't it be something like a root lesion?
Pure motor radicals can be involved, sir.
So where do you get that kind of a picture?
Sir, in acute intermittent porphyria, then CADP, sir. Then lead, sir.
Okay,
Lead
lead we will keep lower down.
Okay,
But
sir.
CADP,
But the
even
patient,
porphyria is not so common, isn't it? What is
yes,
the
sir.
commoner thing?
CADP, sir. But she
So
did
you
not
don't
have
want to.
any remissions and exacerbations during the disease and no history of any sensory symptoms, sir.
Okay, fine. You can't have pure motor variants.
Sir, it's predominantly motor, sir.
What is predominantly motor? In this patient, or you mean CADP?
CADP, sir.
Right, okay. Okay, fine. So, having shortlisted these three
Yes, sir.
sites, what do you think are the possibilities? Can you go any further, or do you want to?
Yes, sir. Sir, in NMJ, we considered whether there is any possibility of generalized myasthenia gravis, Lambert-Eaton myasthenic syndrome, or congenital myasthenic syndrome, sir. In muscle, FSHD and oculopharyngeal muscular dystrophy, inflammatory myopathies, and inflammatory myositis, sir. Then,
What
in
is the difference between the two? Inflammatory myopathy versus inflammatory myositis. I didn't understand that.
Okay, sir. Spectrum of inflammatory myositis, sir. Including dermatomyositis, polymyositis, and inclusion body myositis, sir.
Okay, so what is inflammatory myopathy?
Sorry, sir. Immune mediated myopathies.
Okay, like
Anti SRP and HMG CoA reductase myositis, sir.
Fine, fine. Yeah, proceed.
Okay, sir.
Siddharth.
Sir,
Siddharth,
morning, sir. Yes, sir.
No. Given the pattern of evolution of the weakness,
yes, sir.
Starting with the bulbar, going on to involve the facial, then the neck muscles, and then the proximal muscles of the limbs.
Yes, sir.
Given this pattern of evolution, we agree with the NMJ, muscle, anterior onset, all that is possible. Any of those are possible.
Yes, sir.
Do you have any particular disorder which occurs in this way?
That is exactly what I was also asking in the beginning.
Yes,
Given
sir.
the pattern and the age.
Okay, sir.
Now you have given generic possibilities. Given this patient, would you want to shortlist this further? Do you want to add or subtract?
Paraneoplastic, sir.
Yeah, paraneoplastic myopathy, you mean?
Paraneoplastic, which structure? Yeah.
Myositis, sir.
Not NMJ. You have already included LEMS.
NMJ, sir. Yes, sir. LEMS, sir.
But do you see so much of wasting in LEMS?
No, sir. Wasting is not prominent in LEMS, sir. And there is no, after exercise, there is no improvement also, sir, by history, sir.
Siddharth, you mentioned Musk.
Yes, sir.
I know it's the influence, probably, I am not sure. I know it's the influence of possibly Balaji. Okay. So, do you consider Musk as a possibility with this pattern of evolution?
Yes, sir. Yes, sir, we consider, sir.
Yeah, okay. Then why don't you talk about it? Can all the
all the features can be explained, sir. Ptosis, bifacial, and bulbar weakness
no, not that. That is, of course, yes.
Yes, sir.
I'm asking of the wasting and the weakness.
Yes, sir. Wasting, tongue wasting, and facial wasting, and muscle wasting is noted in Musk myasthenia syndrome, sir.
Right. Okay.
And after what period of duration do you see that?
Sir, long standing, sir, like 2 to 3 years. Sir.
Okay. 2 to 3 years.
So arrange your disorders now. Apart from saying NMJ, muscle, AHC, what are all the possibilities that you are considering?
First, I'll consider Lambert-Eaton myasthenic syndrome, sir, Musk myasthenia, sir. Then I will consider in muscle inflammatory myositis, oculopharyngeal muscular dystrophy, and FSHD, sir. Then finally, I'll consider bulbar onset ALS, sir.
Again, you're going on to the same condition, all those conditions. Okay. Right, fine. Basu, anything else? Or let him continue?
Let him proceed, sir.
Okay,
Right, sir.
Sir, patient is conscious, oriented, no neurocutaneous markers, generalized thinning is present, tattooing marks is noted in forearm, vitals are stable, the height neck ratio is 11.9, the single breath count is 22, higher mental function normal, sir, memory normal. She had lower motor neuron type of dysarthria, more of a guttural dysarthria than lingual and labial dysarthria. Her MMSE is 28/30. Olfactory nerve testing is normal. Visual acuity is 20/70. Field of vision and color vision is normal, and fundus is normal. She had bilateral partial ptosis, which is more in the left side than on the right side. There is no fatigability. There is ice pack test is negative. Extraocular movements are full and free. The pursuits are smooth and full, and saccades are normal on both sides. There is no nystagmus. Pupils bilateral 3 millimeter, equally reacting to light. Direct light reflex is present, and indirect light reflex is present on both sides. And accommodation reflex is normal on both sides. She had wasting in the muscles of the mastication, which was more in the left than in the right. She had bitemporal hollowing, bilateral temporalis and masseter were weak, and opening of jaw is normal, and sensory trigeminal sensory is normal, and jaw jerk is not present. Corneal and conjunctival reflex is present on both sides, sir. Facial, bifacial weakness is present. Wrinkling of forehead is reduced bilaterally. Bilateral orbicularis oculi is weak, and the patient is not able to blow the cheek and whistle. Bilateral orbicularis oris is weak, and the orbicularis oris weakness is more than the orbicularis oculi weakness, and the weakness is more on left than in the right, sir. And facial sensory is normal, sir. So this is the wasting. We are able to witness the bilateral partial ptosis, which is more on the left side, and there is bitemporal hollowing is also present, sir. Rennie's test is air conduction more than bone conduction on right and left, and Weber's there is no lateralization, and no nystagmus and no swaying is present, sir. Bilateral palatal movements are reduced, and right is more than the left, and gag reflex is present, sir. Turning of there is left sternocleidomastoid is more thinned and wasted, sir, and turning of neck side to side and shrugging of shoulder is weak on both sides, sir, and left side is more involved than the right side, sir. So this is a picture showing that in the left side, the sternocleidomastoid is very thinned out, and it's like cord-like, sir. And there is no wasting or fasciculations noted, sir. Tongue appeared larger, sir, macroglossia, and glossitis is present, sir. She is able to protrude her tongue, and there is no deviation of tongue on protrusion, sir. And she is not able to press against the buccal aspect of both sides of cheek, and the side-to-side movement of the tongue is restricted, sir. The tone is reduced on the palpation of the tongue, sir. So this is a large tongue with smoothened appearance, sir. So this is evolution over the years, sir. This was before.
Okay, Siddharth.
Yes, sir.
Just 1 minute.
Yes, sir.
You mentioned the one thing about the no sustained hand grip.
Yes,
but
sir.
all the features that you have described here, including the wasting in the neck and all that,
Yes,
can't
sir.
it fit into a myotonia?
Yes, sir.
Especially the temporal hollowing.
Yes, sir. Faces, sir.
What about the masseter?
Masseter is weak, sir.
Okay. No, I'm from the history,
Yes, sir.
I think you should have included myotonia also. I forgot to mention it that time.
Yes, sir.
Especially with the entire. You didn't mention it.
I mentioned as no stiff sustained hand grips, sir. Sorry, sir.
No, that was there in the negative history.
Okay,
but
sir.
in your differential, just based on that,
yes,
on the
sir.
history of no sustained hand grip, can you rule out a myotonia?
No, sir. No, sir. Myotonic dystrophy is also a possibility, sir.
Okay.
Yes, sir.
Right, go ahead.
Yes. Sir, this is a photos serially, sir. This was taken 7 years back, sir, and this was taken 3 years back, and this was taken 1 year back, sir. Bulk, sir. Mid-arm circumference is 24 centimeter on the right and 23.5 on the left, sir. And in the forearm, it is 19 centimeter on the right and 17.5 on the left, sir. And mid-thigh is 36 on the right and 34.5 on the left, sir. And leg is 30 on the right and 29.5 on the left, sir. So wasting was noted more in the mid-thigh on the left when compared to right, and in the mid forearm, sir. Sir, this is a picture showing the forearm, sir. There is there is no much of a hand thinning in the muscles of the hands, sir. More in the
Right.
mid forearm on the left, sir. This is a weakness which is more in the anterior aspect in the quadriceps wasting, sir, and it is also observed more in the left, sir. But there is no wasting in the anterior aspect of leg. There was no EDB wasting, sir, and there is no wasting on the posterior aspect of leg, sir.
Okay.
Tone, sir, it is upper and lower limb tone is normal on both sides. Power, sir, neck flexion was weaker, sir. It was 4 minus, sir. There is no involvement of the muscles of the scapula, sir. There is no winging of scapula, sir. In shoulder, abduction was weaker, sir. It is 4 minus on both sides compared to adduction, sir. And flexion was weaker than extension, sir. Power is 4, sir. Elbow extension was weaker than flexion, and palmar flexion and dorsiflexion is 4 plus on right and 4 on the left, sir. And all the intrinsic muscles of the hand, thenar, hypothenar muscles and lumbricals, intraossei and hand grip was weak on both sides, sir. There was no myotonia, sir. Power of the lower limb, flexion of the lower limb is weaker, sir. 4 minus compared to extension 4, sir, on both sides, sir. And adduction power was 4 plus on both sides, sir. Knee extension was weak, sir, and flexion was knee extension was 4 minus on both sides, and flexion is 4 on both sides, sir. And ankle dorsiflexion is 4 minus on both sides, and ankle plantar flexion is 4 plus on both sides, sir. This is a video while asking to get up from sitting position. She is not able to get up even with the armrest support, or she needs the help of the attenders to be lifted up, sir. But she is able to walk, sir. So in lying down position, though she is having 4 minus power and she is able to walk, her main weakness is from getting up from the sitting position, sir.
So which muscles are weak here?
Sir, so to get up from the squatting position, she has to flex forward, sir. First, dorsiflexion of the ankle, tibialis anterior, then axial muscles, erector spinae and iliopsoas, sir, hip flexion. Then for hip extension, quadriceps, mainly rectus
No.
Okay,
See, you're just naming the muscles. She
Yes,
is
sir.
unable to get up from the sitting position, but once she gets up, she is able to walk.
Yes, sir. More
So-
of hip, proximal muscles of the lower limbs, sir.
All of them.
No, sir. Hip flexors and erector spinae, sir. Spinal muscles, sir.
Which one do you require to get up? Hip flexor or hip extensor?
Hip extensors to lift off, sir. Hip extensors, gluteus maximus and quadriceps for extension of knee, sir.
Right. So both are weak, no, compared to.
Yes, sir.
Once she's standing, she's able to stand, isn't it, without support?
Yes, sir.
She's
She is
also
able to
walking
stand
without
and walk,
support.
sir. Yes, sir. She walks without support, sir.
So maximum weakness is in which muscles?
What
about lifting the hands above the head?
Sir,
shoulder?
4 minus abduction, sir. 4 minus abduction on the both sides, sir, right and left, sir. She's not able to lift fully against resistance, sir, but she's able to lift against. We are able to overpower her, sir.
What is the pattern of weakness here?
Sir, non-pyramidal pattern of weakness, sir.
Non-pyramidal, okay, fine, but does it see there are certain myopathies and dystrophies which have a very typical
Selectivity of involvement, sir.
picture of progress
Here,
and
yes,
pattern.
sir.
So
Here knee extensors, quadriceps and hip
Siddharth,
extensors are weak, sir.
Siddharth,
Yes,
which
sir.
group of muscles are maximally affected?
Sir, quadriceps, sir. Lower limb,
No,
sir.
no,
Proximal
group
lower
of
limb.
muscles. Which group of muscles? How do we generally say when the person has
Sir,
a muscle?
lower limb proximal and upper limb distal muscles are wasted, sir.
lower limb, proximal, upper limb, distal. Distal is weaker than proximal in the upper limb, is it?
Yes, sir.
Is the pelvic girdle muscles, are the pelvic girdle muscles affected?
Hip extension and knee extension is weaker, sir. Also, hip flexion is also weaker, sir.
So, sir, see, sir asked you a question. Which pelvic girdle muscle, which are the muscles in the pelvic girdle? When you see limb girdle dystrophy, you say no?
Yes,
So,
sir.
what do you mean by that? Limb and girdle, which girdle? What are girdle muscles? Anybody else? There are other PGs, no, here. Anybody else? Anyone can answer.
There are other Chengalpet PGs themselves.
Nobody? Are they there or not?
Yes, sir.
Oh, they're all there.
Your colleagues are there now. Ask one of your colleagues what they think about it.
Sir, hip flexors and extensors are girdle muscles, sir.
Continue. Your name, Ma?
Sir, myself, Dr.
Flexors.
Sangeeta Meena, sir, from Chengalpattu, sir.
Okay. Another presenter. Yeah, go ahead.
Yes, sir.
Yeah. And what about the abductors and adductors? Hip.
Sir,
Which are the
they are
hip
not-
abductors?
They are not much weaker, sir. 4 plus power on both
No,
sides.
they
sir.
are they not girdle muscles?
Yes, sir.
And then, so we are asking you, what are the girdle muscles? You should name them. Are they weak in this patient?
Sir, hip flexors and extensors are weak in this patient, sir.
Okay. So tell me now, which muscles you require for getting up and which muscles you require to maintain a standing posture?
Sir, for getting up, we require hip extensor, sir, for lift off, sir. Gluteus maximus, sir. Then we need a knee extensor, sir. Quadriceps group of muscles, sir. Then for standing, we full hip and knee extension is required, sir. Also, the axial muscles like erector spinae is required, sir, for maintaining
Right.
the upright posture and balance, sir.
Okay. Is the pectoral girdle affected in her?
Yes, sir. She has a difficulty in turning around from side to side, sir.
No. Pectoral girdle muscles, are they affected?
No, sir. No, sir.
Sir, Vasu sir asked you whether
Okay,
she
sir.
had difficulty in raising the arms.
Abductors.
That is where the whole discussion started.
Yes, sir.
Does she have difficulty in raising the arms?
Yes, sir. She has difficulty in raising arms above shoulder, sir. But that
Then
is
why
not.
do you say the pectoral girdle is not affected? What muscles constitute in raising the arm?
Sir, shoulder abductors, sir.
Okay.
Continue.
Yeah.
I'm Dr. Allegason.
Yes, sir.
Yes, Allegason. Go ahead, sir. Professor Allegason. Go ahead.
So in this case, both upper limb, lower limb, proximal muscle and distal muscles are involved, sir. But predominant involvement is the hip, proximal lower limb and distal upper limb, sir. As per the presentation.
Yes, sir. But Vasu was asking whether she had difficulty in raising the arms. Then the discussion started as to what muscles are affected, and then came on whether it is pelvic girdle or pectoral girdle, because he said name those muscles which he thought was maximally affected. That was, he thought it was gluteae and quadriceps which are maximally affected. But then we wanted the group of muscles, which group of muscles are affected. That's how the discussion went on.
Yeah. So now it looks as if even the shoulder muscles are weak, isn't it?
Yes, sir.
So it is not just, so there is a pattern here.
Yes, sir.
More of distal, semi-distal and distal in the upper limbs.
Yes,
And
sir.
predominantly proximal in the lower limbs.
Lower limbs, sir.
But
Right,
upper
okay,
limbs
then.
also proximal involvement is there, Siddharth.
Yes,
Yes, sir.
it
Yes,
is.
sir.
It is there.
Yes, sir. In the later part of illness.
So you see, that is what you should bring out, how it has evolved. You
Yes,
can't just
sir.
say distal in the upper limbs and proximal in the lower limbs.
Okay, sir.
That is not what is happening here.
Okay, sir.
Right.
There is no
Finished?
myotonia. There is no myotonia,
Okay.
sir. There is no facilitation of power of muscles post exercise, sir.
One other question, Siddharth.
Yes, sir.
During these 7 years, she
Yes,
has
sir.
not had pain. It is a painless weakness. Am I right?
Sir, occasionally she is having muscle aches, sir, but it's not a consistent pain, sir.
Right. Because we were considering inflammatory muscle disease, I just
Yes, sir.
wanted to stress on that point that she has not had pain right through the illness.
Yes, sir.
Okay. Continue. Not that it
sir.
is necessary, but it is
Okay,
not
sir.
right.
The corneal reflex is present on both sides. The conjunctival reflex is present on both sides. Abdominal reflex present in all 4 quadrants, sir. There is no beaver sign. And plantaris flexor on both sides, sir. Trapezius reflex not present, sir, on both sides. Biceps 2 plus on right and left, and triceps is 2 plus on right and left. The supinator is 2 plus on the right and left, and there is no finger flexor, sir. And knee reflex is 2 plus on both sides, and ankle reflex is 2 plus on both sides, sir. So there is retained reflexes, sir. Sensory, fine touch, vibration, joint position sense, and spinal vibration is normal, sir. Finger nose and finger nose is normal on both sides, sir, and heel shin test is normal on both sides, sir. There is no postural hypotension, no resting tachycardia, no trophic changes, no abnormal sweating or flushing, sir. No resting tremors, no bradykinesia, and no rigidity, sir. She has scoliosis and kyphosis, sir. No gibbous, no spinal tenderness, sir, and cranium is normal, sir. Other system examination is normal, sir.
Right.
So,
what about the muscles themselves? Have you palpated the muscle?
yes, sir. No, non-tender, sir. No tenderness, sir.
Okay.
And what is the pattern of wasting in the limbs? In the limbs?
It is more in the proximal low limbs, more of quadriceps wasting, sir. There is no wasting in the legs, sir, and wasting is present in the mid forearm, more on left side, sir.
Okay.
And of course, there is facial wasting, isn't it?
Yes, sir.
That's
Facial
right.
weakness.
No,
Yes,
I was asking only about the limbs. Facial
Limbs,
is
okay.
obvious. Yes, sir.
You finished?
yes, sir.
So does anybody else want to discuss the case? I mean, give a differential. How do you proceed after the examination? He has given a set of differentials at the end of history.
Sangeeta, you are there. We know only you. So what do you think?
Hello?
Sangeeta
Anybody?
is there. Then Kritika
Yes,
also
sir.
should be there. Kritika is another presenter. Kritika also should be there. At least Chengalpet PG's.
Yes, sir.
Yeah,
Yes.
go ahead. You know about the case. You have discussed the case, but still doesn't matter. Go ahead.
So first possibility, since the patient has asymmetric involvement, weakness and wasting, there is a pattern of involvement and there are retained reflexes without any exaggerated reflexes. Still, I would like to consider muscle disease itself, sir.
Continue. You are Sangeeta or Kritika?
Sir, I'm Kritika, sir.
Okay, go ahead.
The patient also has a bulbar involvement with bifacial involvement. So there is in bifacial also he told that orbicularis there are specific group of muscles which is involved, sir. So the first possibility is though it is not treatable, FSHT is one possibility, sir. OPMD FSHT, considering her age and the pattern of the preservation of asymmetricity through the illness, FSHT is one possibility, sir. OPMD, because late onset with bulbar involvement and proximal muscle involvement, OPMD is also possible, sir. And we have to consider inflammatory myositis also in this case, with the pattern of involvement of lower limb proximal and upper limb mid forearm involvement. Inclusion body myositis is one possibility, sir. Fourth possibility is still anterior hansel is one possibility, sir.
Siddharth,
Hello,
you
sir.
mentioned something about orbicularis oculi and orbicularis oris. You said
Yes, sir.
there's a differential weakness. What is it?
Yes, sir. She is having lower facial weaknesses more than the upper facial weakness, sir. And it is also asymmetric, sir, more on the left side, sir.
Does it have any significance?
Sir,
yes,
there
sir.
is no...
One condition where we can get orbicularis oris weakness more than orbicularis oculi weakness is leprosy, sir. But we don't consider that possibility here, sir. But there are sensory. There is no sensory, but pure neuritic leprosy is also possible. But we don't consider leprosy here, sir, because wasting is more.
No,
asymmetricity
not
is more.
necessarily, Kritika, not necessarily leprosy. Any
Okay,
condition whereas specific branches of the facial nerve are differentially involved. It's a differential involvement of the branches of the facial nerve. Any condition, if
yes,
it happens,
anterior
it can
hansel
give
also.
rise to, including trauma. Yeah. It can also happen if there is a differential involvement of the anterior hansels.
Yes,
So
yes,
I just wanted to know why he was specifically mentioning that the orbicularis oris is more involved than the orbicularis oculi. So whether he had
So the
anything in
patient,
mind. Yeah, go
yes,
ahead.
the patient was not able to purse the lips, sir, but she was able to close the eyes well, sir, tightly. There was obvious difference in between, which we couldn't explain before the diagnosis, sir. So we considered more of anterior hansel possibility. That is why we wanted to highlight that point, sir.
Okay, so selective involvement of certain muscles.
Yeah,
Or
yes,
differential
sir, yes,
involvement of certain muscles of the face.
yes, sir. Differential involvement of the same muscle supplied by the same nerve, sir.
Okay.
Okay.
So
But you see,
what is
the
your
thing
conclusion?
No, sir. The thing is, overall, if you look at only now, these people are concentrating only on the weakness, but you also have preserved reflexes right through the illness.
Yes, sir.
Even now, they're all 2+.
Yes, sir.
So
well-preserved
that,
reflexes.
Yes. So where does that leave you? Where does it take you?
Muscle, sir.
Muscle or
muscle,
anterior
sir.
hansel?
Why not neuromuscular junction? Siddharth?
Yes, exactly.
Yes, sir. Muscle and NMG, sir.
Muscle and NMG.
In
So,
both.
so if it is muscle, what is your what are the diseases? Now you come to diseases.
Yes,
now
sir.
It is not enough to say just muscle.
Yes, sir. One possibility, oculopharyngeal muscular dystrophy,
Yes,
sir.
that she said. Yeah.
Myotonic dystrophy, sir. Though myotonia is not there, since proximal limbs are involved, it is possible, sir. Then it can be FSHD pattern of weakness, sir.
Okay.
Then inflammatory myopathy is still possible, sir.
FSHD, you said considerable proximal weakness of the lower limbs.
Sir, long duration of illness, 7 years.
Long duration is there, but but the thing is, you see, early in the illness itself, they will develop weakness of the anterior compartment.
Yes, sir.
They can develop early foot drop. There is specific wasting of the tibialis anterior.
Yes, sir. That is not present in this patient.
It is markedly absent in this patient.
Yes, sir.
Whereas the quadriceps is strikingly affected.
Yes, sir.
So the pattern is actually reversed. It is not typical of FSHD.
Yes,
so
sir.
Don't go only by the face.
Okay, sir.
Clinically, I mean, the phenotype, there are these differences.
Yes, sir.
Can you think of any other LGMD patterns which can fit into this?
How about the swallowing? How about the swallowing, Siddharth?
Sir, she has dysphagia. She has dysphagia.
I know. You said that.
Yes,
is
sir.
it variable? Does it vary at times? At times
No, sir.
more difficult, at times less difficult. Pardon?
No, sir. No diurnal variation, sir.
Not diurnal, but no variation at all.
No, sir. No, sir.
Okay. Okay. How is she eating? How is she feeding now?
she's able to eat on her own, sir, but she will take small quantities of food along with water, sir. She has difficulty in swallowing, sir, associated with nasal regurgitation, sir.
And you also said that she has difficulty in moving her tongue inside the mouth.
Yes, sir.
Okay. Side to side.
Side to side, and she's not able to push the bolus back into the. Yes, sir.
So is tongue weakness another feature which you see in FSHD?
No,
is
sir.
tongue weakness a character of FSHD?
No, sir.
No. So these are small points, but these point you, I think clinically the phenotype, it points away from FSHD.
Yes, sir.
And you said something about macroglossia.
Yes, sir.
Now, in the final conclusion, when you summarized, you have
Yes,
not
sir.
taken that into account. Is it macroglossia or is it looking big because the rest of the face is wasted?
It is looking big, sir.
So it is not actual macroglossia.
Okay, sir.
No, I am asking you.
Yes, sir. The tongue is very flaccid, sir, with a coated appearance, and it is present from both the angles of mouth, sir.
It is what?
It is extending on protrusion. We are able to see your tongue from one angle of mouth to the other, sir. Completely, there is.
There is no shrinkage. What you are saying
there
is
is no.
There is no wasting, sir.
But it is flaccid.
Yes, sir. Flaccid,
that is what
sir.
you are saying.
Yes, sir.
Okay. So what happens to the tongue in musk?
Atrophy is expected, sir.
By 7 years, you should have seen atrophy.
Yes, sir.
So that is not there.
Yes, sir.
Diurnal variation is not there.
Yes, sir.
Diplopia is strikingly absent.
No diplopia, sir.
So among the extraocular muscles, only there is ptosis. All
Yes,
your
sir.
eye movements are normal. So
Yes,
does
sir.
that fit in? Does that fit in with any kind of neuromuscular junction?
No, sir.
Clinically?
Usually we will have involvement of muscles of extraocular movement along with ptosis, sir.
Yes. So by this time, that should also have been there. That is not there.
So these are the difficulties we are having, and that is why you are presenting this case as an undetected case, undiagnosed.
Sir,
So,
sir.
Allegation ponga, solunga.
Sir, I will favor muscle localization, sir, because the very slowly progression over years. Bitemporal hollowing, mesiter, sternocleidomastoid muscles are wasted. Distal upper limb is more involved, and proximal lower limb is more involved. Macroglassia, reflexes preserved. So everything is fitting with the IBM, sir. The only point which is against is the ptosis, bilateral ptosis.
Okay.
Yes. Age also. Age at onset, around 60 years of age. Female. Yes. All these things favor IBM. But only thing is IBM, the characteristic onset is in the upper limbs. It's not in the face. The characteristic
distinct pattern of weakness is not seen, though.
Yes.
Yeah, it's not specifically confined to quadriceps or the extensor group. But still, yes, as we do not know what
muscle, yes,
all possible. Yes.
Other PGs, somebody asked whether it is LEMS. So are there any subtle autonomic signs? Somebody was asking.
No, sir. No autonomic signs, sir.
Okay.
And
Vasu, there are 3 cases.
And there is no loss of reflexes. No loss of reflexes.
Balaji wanted you to distribute the time accordingly. 3 cases.
Fine, sir. We'll wrap this up.
Shall we proceed with the investigation, sir?
Yes, please.
Yes.
Sir, CBC is normal, peripheral smear normal, fasting, postprandial and FLP is normal, RFT is normal, sir. There is elevation of transaminases.
No, tell us only the ones which are relevant.
Yes, sir. OTPD is elevated and CPK is elevated, sir.
Marginal, very marginal.
This is just marginal.
Yes, sir. 263, sir. Normal upper limit is 180, sir. Video laryngoscopy is normal, echo is normal, sir. TFT, ESR and CRP is negative and viral markers are negative, sir. The anti-ACHR and anti-MuSK is negative, sir. RNS, no decremental pattern, sir. NCS was normal, sir, except for sural snaps were not obtained, sir, and facial amplitude were reduced, sir.
When you say video laryngoscope is normal, they did not detect any weakness, is it? Palatal pharyngeal
Sir,
weakness?
cords they saw for any mass
Okay.
and movement
Only
of
the
cords,
cords,
sir.
right?
Yes,
Okay.
sir.
Continue.
EMG patient was poorly cooperative, sir, was done in right trapezius, normal amplitude MUAP with spontaneous activity and complete interference patterns, sir.
No, what do you mean spontaneous activity?
Sir, few spontaneous activity were noted, sir.
No,
on
spontaneous activity, even end plate potentials and end plate spikes are normal spontaneous activity. No, what do you mean spontaneous activity?
Sir, few fascicles
Did
were
you
noted,
see
sir.
fibrillations and fasciculations?
Yes, sir. Fasciculation was
few
present, sir.
few fasciculations were
fasciculation.
seen.
Okay. Okay. So you must say that there is evidence
Okay,
of
sir.
denervation.
Okay, sir.
Uh,
MRI brain was normal, sir, and MRI cervical.
Only one muscle you did?
Yes, sir.
Why? Why trapezius? Trapezius is not really a weak muscle in this patient, no?
Yes, sir.
Any other PG, any other muscle you would have chosen to needle?
Shorted of biceps, sir.
Why?
What are the muscles
Sir,
commonly
I would have,
do?
sir, usually we do deltoid, sir.
Delta.
Quadriceps, sir. For this patient, we would have definitely done a quadriceps, sir. And forearm muscles was wasted. So what is the less wasted muscle? We would have, since left is wasted more, we would have put the same muscle in the right side, sir. And we should have chosen 4 quadrants in the same muscle, and one distal, one proximal muscle should be done. So for distal muscle, tibialis anterior could be chosen, sir. For one proximal muscle in the arm, deltoid, distal muscle, finger flexors of the right side, and lower limb, quadriceps and tibialis anterior would have we would have chosen, sir.
Why didn't you do it? Then you would have had your diagnosis, no?
Sir,
Now, this is not giving you any diagnosis. Based on one muscle EMG, can you make a diagnosis? Anyway, proceed.
Okay, sir.
Siddharth, what is your impression on EMG?
Sir, muscle, sir, complete interference pattern, sir.
No, you can't give any impression with this EMG.
Yes, sir.
You can't give any impression with this EMG.
Why do you say muscle?
Patient had complete interference pattern, sir. Though we cannot say with the single muscle, sir. She was little uncooperative for EMG, sir. Sorry, sir. So that's why we couldn't proceed with her.
Duration of the MUP? Duration,
Yes, sir.
amplitude of the MUP?
Sir, I'll.
Siddharth,
Sir?
your EMG is incomplete.
Yes,
Okay.
sir.
You have done one trapezius and you have mentioned normal amplitude MUAP. You have not mentioned the duration, you have not mentioned the morphology of the MUP. And you have written spontaneous activity. We don't know whether it is fibrillation, fasciculation, end plate spike, or end plate potential. And you say that there is incomplete interference pattern. You have not mentioned the amplitude of the interference pattern. So how can anybody make a guess as to whether, guess, how can anybody say whether it is a myopathic pattern, normal pattern, or a neurogenic pattern? This EMG is inconclusive. You go ahead and I'm not criticizing you. I'm trying to teach you. Go ahead and do a proper EMG in this patient.
Okay, sir.
And even if she is not cooperative, the one muscle you would have chosen, it's not trapezius. You would have chosen some other muscle rather than trapezius if she was not cooperative. Right. Anyway, go ahead.
Okay, sir. Sir, ANA profile was negative, sir. Myositis profile, including CN1A is negative, sir. Paraneoplastic profile was negative, sir. We sent muscle biopsy, sir. It showed, sir, vastus lateralis, sir, on the right, sir. Sir, it showed cryosection showed muscle with early effacement of fascicular architecture with endomysial infiltrate associated with few myonecrotic fibers, and there was endomysial infiltrates, sir, and suspicion vacuoles were noted in MGT, and COX SDH deficient fibers were seen, sir. And P62 ubiquitin fibers on immunostaining was positive, sir. So the histological features that was favoring when inflammatory myopathy with degenerative changes and secondary mitochondrial features suggestive of inclusion body myositis, sir.
But inclusion bodies they have not mentioned, isn't it? You have done EM?
Sir, they have done HNE, MGT, and COX-ST, sir. Also, they have done immunohistochemistry, sir.
But you have not described anything like infusion bodies here. What did you mention?
Sir, cryosection shows muscle with early effacement of vesicular architecture.
No, endomycel. See, endomycel infiltrate means it is a polymyositis type of picture, not dermatomyositis.
Yes, sir.
Dermatomyositis is perimycial
Yes,
and
sir.
perivascular.
Yes,
If you
sir.
say endomysium, it means obviously you are dealing with a polymyositis type of picture. So then
he has mentioned rimmed evacuation, isn't it?
Yes, sir. Rimmed vacuoles are present in this patient along with megaphagocytosis, sir.
Okay. Okay.
And this COX-STH deficient fibers and P62 is very specific for IBM, sir.
IBM.
So this is what they give for IBM, sir. Rimmed vacuoles with vacuolar degeneration by GMT associated with this COX-STH deficient fibers is typical of IBM, sir. Also, this P62 immunostaining is also very specific for IBM, sir.
Right.
And this anti-cytosolic 5 C1a in myositis profile can be positive in IBM patients, sir. But though the muscle biopsy is the gold standard, so including negative anti-C1NA with muscle biopsy positivity can be considered for IBM under the criteria for the IBM, sir. Age of onset more than 45, duration of symptoms more than 12 months, and creatine kinase is not much elevated, and quadriceps more weaker and finger flex are weaker, associated with endomysial infiltrate, rimmed vacuoles, and this immunostaining, sir.
Right.
And the muscle groups in muscle MRI, it is asymmetrical involvement of finger flexors, mainly FDP and quadriceps. In quadriceps, usually rectus femoris is paired and there is proximal to distal gradients, sir, with fatty infiltration. And in the legs also, the medial gastrocnemius is mostly involved with sparing of tibialis posterior and soleus group of muscles, sir. There will not be much of a edema and there will be more of fatty infiltration, sir. This is the group of muscles that is most commonly involved. FDP in the forearm, and there will be sparing of sartorius and more involvement of vastus lateralis and more involvement of gastrocnemius, sir. This is the muscle MRI of patients, sir, which also showed fatty infiltration in all the quadriceps muscle, and it is more in the vastus muscle, and it is less in sartorius, sir, and it is asymmetric, sir, more on right than in the left, sir.
Right.
Siddharth, how about the facial involvement in IBM?
Yes, sir. That's what I have put few slides, sir. Macroglossia in IBM, sir. There are few case reports of macroglossia in rapidly progressive inclusion body myositis, sir. So there are case reports on that, sir. And macroglossia or enlarged tongue is a rare but recognized feature in some patients with IBM, and it has been reported particularly in cases with rapid disease progression and prominent bulbar involvement, including dysphagia and facial diplegia, sir. And the macroglossia in IBM may serve as an indicator of disease severity or response to immunotherapy, but it remains as under-recognized and atypical manifestation that can complicate diagnosis due to overlap with other conditions like amyloidosis, and it is rare in IBM, sir. Macroglossia may indicate a more aggressive disease course or distinct IBM phenotype, sometimes associated with other autoimmune conditions, sir. And IBM is also known to have this axial myopathy onset, sir, and it is also known to have this drop dead involvement, sir. And it has been also told that the paraspinal affection may be the first complaint in the myopathies, FSHD and inclusion body myositis, and it is known to have drop dead and camptocornea, sir. There are case reports of IBM presenting with severe camptocornea, sir. Coming to facial involvement, they compared face involvement in FSHD and IBM, sir, and it was thought that the estimate of frequency of facial impairment in IBM is more than half of the patients, sir. So, like FSHD, facial involvement is also common in IBM, sir, and there are case reports of head drop and facial diplegia along with macroglossia in patients with sporadic IBM, sporadic IBM, sir. So these are the two case reports that have been presented like this, sir.
Siddharth, IBM and ptosis.
Yes, sir. Known to involve, sir. Sir, there can be it is more of a disease of females, sir, and asymmetrical onset, and they have given involvement of more of quadriceps and forearm flexors, sir, and ptosis involvement is also noted, sir.
Did you suspect IBM before the muscle biopsy report?
We suspected muscle, sir, muscle disease, sir.
That's right.
Yes, sir.
Not that is you based it on your EMG findings.
No, sir, not on EMG findings.
Then
Based on what then? Your
clinical-
CPK is also not elevated.
Sir, retained reflexes.
Fine. Okay, so that was the only point.
Retained reflexes. Siddharth, even your EMG findings
Okay,
with the
sir.
interpretation of myopathy with the spontaneous discharge is obviously mixed. Neuropathic and myopathic, that is a hallmark of IBM.
Yes, sir.
Siddharth எல்லாத்துக்கும் எஸ் சொல்றீங்க அவர் என்ன சொல்றான்னு புரிஞ்சுட்டீங்களா தெரியல எனக்கு.
Okay, sir.
So why did you suspect, if you had you suspected IBM before the muscle biopsy report came? Was it your diagnosis?
No, sir.
Right. Thanks.
What was your diagnosis? What was the unit diagnosis?
Oculopharyngeal muscular dystrophy, sir.
Okay. Fair enough.
Or
Yeah.
Anterhorn cell disease, sir.
Anterhorn. Okay, fine.
Again, sir.
Yes, sir.
What made you suspect IBM?
Because of the preserved reflexes, the classical wrist flexors are more involved than the wrist extensor, macroglassia.
அங்கப்பா பிளஸ் ஒரு பிளஸ் தான் வித்தியாசமா 4 plus 4 minus 4 plus அவ்வளவுதான் வித்தியாசம். Not much of a difference. Striking
Basically,
difference or point out பண்ணல.
Finger drop and all those things are not there in this
Yes, sir, not in this patient, sir.
You see that very early on in the onset of the patient, and very often they are mistaken for they are mistaken for inflammatory muscle disease, and many of the patients are put on steroids to which they do not respond. That is a usual history. Okay, fine. Thanks.
Yes.
Thank you. Nice case, ma.
Thank you,
Siddharth,
sir.
good case.
Thank you, sir.
Very good
Thank you,
case.
sir.
Foxed all of us. Okay. Thank you, Shankar. Thank you, Professor Shankar.
Next.
Yeah.
Next case.
Next is my case, sir. 1 minute, sir.
Natarajan sir, should we try to finish in 30 minutes each?
அப்படிலாம் இல்ல பாலாஜி உங்களுக்கு போட்டிருக்கேன்னு சொன்னாரு எனக்கு அவ்வளவுதான். நமக்கு வந்து we can 2 hours we can extend by another 15-20 minutes.
Okay. So they can have 40 minutes each.
Yes, sir. That is because Balaji, see, it's up to the presenting unit to take time as they feel, whichever needs more discussion, whichever is less, like that. Nothing hard and fast, sir.
Okay, sir.
Good afternoon, sir.
Yes, ma'am.
My screen visible? Am I audible, sir?
Yes, please. Both.
Thank you, sir. Sir, good afternoon, professors and friends. I'm going to present a case of intellectual disability with neuroregression when growth slows and skills fade. Next. I would like to start from the perinatal history itself. The child is born third to third degree consanguineous parents by normal vaginal delivery. No history of reduced fetal movements in the antenatal period. No history of illness or comorbidities in the mother during antenatal period. History of prolonged labor in the mother present. No history of NICU care for the baby. Took breastfeeds. Discharged in 3 days. Next.
Ma, what is the age, ma, at present? Age of illness?
13 years. 13 years child, sir. 13 years
Okay.
female child.
Okay. Carry on.
Next. By about 3 months of age, mother noticed that the child is lying still without much of the activity, but was stiff upon lifting. She also noticed that there was frequent to and fro movements of the eyeballs. Baby could track things moving around her and would turn her head towards the sound of the mother. By 4 months, mother consulted a pediatrician for the above said complaints. Baby was given vitamin supplements and advised to evaluate at ICH if the developmental delay persists. Baby didn't show any improvement in motor and social skills. Next. Baby didn't show any improvement in motor, language, and social milestones. No, previously. Baby didn't show any improvement in motor, language, and social milestones. She was able to identify her mother. By 8 months of age, she was taken to ICH. Blood, urine, metabolic screening was done. MRI was done, and diagnosis of HCG sequelae is made and advised physical therapy. She was given regular physiotherapy at ICH till 5 years of age. Next. By 5 years of age, child could sit with support. Head control was achieved. She attempts to stand with the support of walker for a few minutes. History of head nodding was present. History of clumsiness when handling the toys or tumblers was present. She had achieved bladder and bowel control. No history of incontinence or inappropriate voiding. Child could recognize the family members and would say Amma, Appa, and Anna. No history of irritability, excess cry, or anger outbursts. No history of feeding difficulty. No history of mother accompanied her to special school. History of siluria was present. Next. After 5 years of age, physical therapy and special schooling was stopped as they shifted to a newer place for residence. Upon 8 years of age, mother was giving physical therapy at home itself. Child was not admitted as inpatient in all these years due to any other illness. She attended menarche at 12 years of age. Next. For the past 1.5 years, mother noticed a regression in the form of she was reeling when she was made to sit, and she was not able to sit even with support. She is not able to hold her head, and usually it will be either in an extended or a extended position. History of decreased food intake present, and she avoided food most of the time. History of taking prolonged time to swallow and frequent regurgitation of feeds, mostly for liquids, was present. History of reduced speech output was present. Next. Previously, her mother will leave her under the care of her brothers or grandmother when she goes out. Now she needs continuous care. She wants her mother by the time. And currently, she had recurrent seizures for the past 10 months. Semiology was head turn to the right with eye deviation to right, followed by tonic positioning of left upper and lower limbs, lasting for about 1 minute. History of deviation of mouth to mouth, angle of mouth to right during episode. History of oral secretions and associated grunting was presented. No history of post-rectal confusion. No history of post-rectal vomiting or headache. Next. Past history, there is no other comorbidities. She was not operated for cataract. No similar illness in the family members. She is on levetiracetam 60 mg per kg per day. Carbamazepine 200 mg BD. Clobazam 10 mg BD. Lacosamide 100 mg BD. Next. So the course of the illness was she was a global developmental delayed child with suggestive history suggests to us spasticity and ataxia. And for the past 1.5 years, she was noted to have neuroregression in the form of lost neck holding along with regurgitation of feeds. Now she had new onset right focal seizures with occasional secondary generalization, for which she has seek medical attention. Next. Summarizing the history, this is about a 13-year-old girl born third to third degree consanguinity, no significant perinatal insult, presented with insidious onset, slowly progressive chronic neurological illness in the form of spastic ataxic quadriparesis with global developmental delay and intellectual disability, with features suggestive of neuroregression and recent onset seizures, probably right frontal onset, left focal seizures for the past 1.5 years. Next. The structures involved would be, since she had history suggestive of ataxia and spasticity, I would like to consider pancerebellar involvement since she had head nodding and also history suggestive of nystagmus, pancerebellum and or its connections, bilateral corticospinal tracts above C3, bilateral corticobulbar fibers or bulbar involvement itself, and seizure should be localized to left frontal with secondary generalization. And global developmental delay and intellectual disability is localized to cortical and subcortical networks. Next. Since this is a chronic onset spastic ataxia syndrome, I would like to consider a genetic etiology itself, probably an autosomal recessive, since her family members are not affected. And out of 3 children, she is the only one affected. So autosomal recessive HSP with cerebellar signs, including SPG 5, 20, 21, 26, 30, 35, 39, 44, and rest of the things are felt to be considered CTX, leukodystrophies, Paul R3 mutation, CoQ10 deficiency, and ataxia with vitamin E deficiency. Though it is less likely, acquired and treatable conditions like vitamin B12, vitamin E, copper deficiency, atriovenous malformations, and aneurysms can also be considered in this patient.
Aneurysm? What aneurysm?
Sir, structural brainstem and cerebellar multiple AV malformations. Structural causes can
before you go to this big list, what does this pattern tell you? I mean, what kind of pattern of progress is this? Well, from what you say, it looks like they were treating her like HIE, isn't it? So they were treating her like a static encephalopathy.
Yes, sir. Yes, sir.
So when did she start regressing? Right from the beginning, she was regressing?
No, sir. She attained some amount of neck control, and she had urine, bowel and bladder control. She was able to say bisyllable samma appa. She was able to notice her mother. She was till 11 years of age. She was able to do all these activities, sir. That is static encephalopathy, somewhat recovering, sir. And from 11 years of age, that is 1.5 years back, she had neuroregression in the form of she was not able to have a neck control. She was having regurgitation of feet. She was always reeling towards one side when was even made to sit with support. She was made to lie down most of the time, sir. So history of HIE, similar to a global developmental delay since birth and stable till 11 years of age. For the past 2 years, she had neuroregression with new onset seizures for the past 10 months, sir.
So tell me 2 things. Now you say stable till 11 years, which means what? Was she actually improving or was she static? There is a difference between the two. And did something happen at 11 years? No, wait a minute. Did something happen at 11 years of age which made her regress further? Was there some trigger? Was there some event or was it spontaneous? How did that happen?
Okay. Yes, sir. Sir, the first question is she was having a global developmental delay. She was acquiring her milestones appropriate only for 2 to 3 years kid till 11 years of age. After that, she was regressing, sir. So the initial illness was static to improving in nature. From 11 years, she didn't have any history of fever or intercurrent illness which provoked a neuroregression. Her mother noticed it to be insidious onset, sir. She was not able to tell the exact time when she had neuroregression, sir.
Okay. And what about the seizures? Are we sure that she didn't have seizures earlier?
Yes, sir. She was not put on any ASMs earlier, sir. Her mother was.
No, that doesn't mean she didn't have seizures. Not being on ASMs does not equal to no seizures.
Okay, sir. Her mother was. We asked for subtle symptoms like any history of head drops, like that. We asked, sir. Her mother was not convinced that she had seizures earlier, sir. It was only recent onset, sir.
Okay.
Excuse me.
So apart,
yes.
Sir, this is Dr. Prakash from MMC. Hello, Kritika.
Yes,
hello.
Sir.
Yes,
yes,
yes, sir. Yes. Yes, sir. You are audible.
What about the consanguinity?
Sir, she's born of non-consanguineous marriage, sir. Third, yes, sir. Third born, sir.
Third born of
Sorry, sir.
non-consanguineous.
Third degree consanguinity. She was married. Her mother married her distant cousin, sir. Third degree consanguinity, sir.
Okay, and any myoclonic jerks? Anything similar history? I mean, myoclonic kind of
No,
jerks.
no,
Any past?
no, sir.
Okay.
No, sir. No history of
And
myoclonic, sir. Myoclonic
okay,
jerks.
and she had
No history of
yeah.
exaggerated startle response.
Okay. So you told some prolonged labor. Oh, it was institutional delivery or home delivery?
Yes, sir. It was institution. Initially, she was admitted at around, her mother was admitted at around 8 a.m. for institution delivery in the nearby GH. Later, she was shifted at around 6 p.m. to the Chengalpattu Government Medical College. And then she delivered at around 9 p.m., sir. At the time, her mother didn't have any recollection of the event that she was placed under NICU care, sir. The baby was placed under NICU care, sir.
You told no NICU. I mean, NICU, how long
No,
she was admitted? Pardon?
No, sir. She was only evaluated initially. APGAR score was put. She was placed by the mother's side immediately upon delivery, 5 to 10 minutes or so after delivery. And the baby took breastfeeds and she was discharged in 3 days, sir.
Okay. Okay, fine. Okay, I just was thinking whether it is just a HIE sequel. Okay, anyway, fine. Okay.
Okay, sir.
Anybody else? So proceed.
Yes,
I think you can proceed.
Okay. Next slide. Next slide. Since the child was not, we were not able to bring the child to the hospital, Dr. Sangeeta ma'am went to the patient's home and took the video and photos, sir. General examination, child was awake, obeyed partially to oral commands, no pallor, no icterus, no clubbing, facial dysmorphism present. That is, she had the dentition was not correct. There were missing tooth, sir. Next slide. Next slide. On finger nose testing, bilaterally, finger nose test was impaired, sir. Both she was not able to do, sir. And left was more impaired than right, sir.
Okay,
Next
but
slide.
does this look like incoordination or does it look like weakness?
Sir.
From the video, it looks as if she is very flail, the hand.
She
looks more flail than ataxic.
That is distal hypotonia is there, sir. Still, she was having spasticity also, sir. Distal hypotonia. She had intention component also, sir. When approaching the nose, she had a difficulty. Okay, sir. Next slide. Next slide.
What about she's not able to walk, is it?
No, sir.
Not able
she
to
has
stand or walk?
No, sir. I will show the video next, sir. The mother usually takes her by the shoulders, sir, and she has knee and ankle contractions, sir. She is made to speak, sir. There is slow scanning type of speech, sir, and there is no. Next slide. She had few beats of beats of downbeat nystagmus was present, sir. Once again, play it, sir. This time, sir. Next. Here the patient had knee contractions, sir. We were not able to extend the knee completely, and there was ankle clonus. patella clonus we were not able to test because knee was contracted. There was no wrist clonus, sir. And distal hypotonia was there, and all reflexes were present. Knee contractions was there, and ankle contractions were there. So lower limb reflexes could not be elicited. Upper limb reflexes was present, sir. Next video. Play the next video. This is how a
Upper
mother
limb
usually
reflexes
lifts her.
present. Upper limb reflexes present. You mean
Yes,
they were just elicitable or they were normal?
just elicitable, sir.
You mean to say they were depressed? Depressed in the upper limbs and absent in the lower limbs.
So absent in the sense we couldn't elicit, sir, because ankle contractions.
But there
was
is
there.
ankle clonus anyway, so that is evidence of pyramidal. What about the knee jerks?
Yes, knee jerk and knee contractions was there, sir. So we couldn't fully extend the knee, sir. Yes, yes, elicit, sir. Here clearly the plantar were bilateral extensor, sir.
Okay.
அப்பா ஏதோ லிங்க் அனுப்பி அட்டெண்ட் பண்ண சொல்றாங்கல்ல, அட்டெண்ட் பண்ணியா?
Next slide.
சாரி நல்லா இருக்குடா டிஸ்கஷன்.
Examination findings: the patient had slow scanning speech, nystagmus, some amount of echoic intrusion was present, outward nystagmus was seen, uvula was in midline, spasticity was present in all four limbs with mild distal hypotonia with bilateral knee flexion contractures and ankle contractures was also present. She had ankle clonus, no wrist clonus. Upper limb was, she was able to lift against gravity in the upper limbs. Lower limbs, she was able to move only with gravity. Bilateral biceps, triceps, supinator, 1+ to 2+. Bilateral knee jerk could not be elicited due to contractions. Bilateral plantar extensor. With even since she was able to, her upper limb power was 3. We would like to consider bilateral finger nose test impaired. So summarizing the history.
Others,
and
please mute your
findings.
audio, please. Others, please mute your audio. Yes, ma'am, proceed.
Yes, sir. So summarizing the history.
Just one question. No KF ring.
Yes, sir. No KF ring. Sorry.
Did you see? Did you look for it or you didn't look for it?
Sir, we were able to examine only with the torch, sir.
Fine.
We were, yes, sir. Yes, sir. We looked
Another
for
thing.
KF ring.
Another thing
So
you have not mentioned the other
telangiectasia.
neurocutaneous markers.
Yes, sir. Yes, sir. Telangiectasias we look for, sir. Tendon xanthomas we look for, sir. Ichthyosis we look for, sir. And neurofibromas we look for, sir. And skin lesion, telangiectasia. That's all, sir.
No, not telangiectasia. Anything else? Anything else on the skin?
Hemangioma, cutaneous hemangioma, sir.
Apart from that. Anything else which progresses with regression, with or without long tract signs, intractable seizures?
BTBGD, you are asking, sir? Biotin time in response to basal ganglia disease?
No, not really. Tuberous sclerosis.
Oh, tuberous sclerosis. Yes, sir. Shagreen patch, Ashley Matthews, and Kathleen spots should be looked for, sir. Sorry, sir.
They also progress. No, there is an inexorable progression. Seizures are usually not controlled with the usual combination of ISMs. Okay, fine.
Yes.
Proceed.
Yes, sir. Yes, sir.
Head circumference was what was it? Any?
Sorry, sir. We were, I didn't look for head circumference.
Fine. Okay.
13-year-old girl born third to third degree consanguinity with history of prolonged labor during birth but no NSU care, had global developmental delay with intellectual disability and early onset spastic ataxic quadriparesis with axial hypotonia with regression during her course of illness. So considering this
and
possibility
seizures.
And
seizures,
yes, sir. And recent onset seizures, focal seizures, sir. Yes, sir. Next.
They are only focal or focal to generalized?
Focal with occasional secondary generalization, sir.
They are not multiple seizure
left
types.
focal. No, sir. Left focal with occasional secondary generalizations. Always left focal, sir.
No, no. You said eyes turn to the right, eyes move to the right, and face
Yes.
goes to the right.
Sorry,
And
right.
she has extensor posture on the left side. Am I right?
Yes,
That's
sir.
what you had showed on the
Right.
slide.
Yes, sir.
So
Yes,
she's
sir.
talking about left frontal focus, I believe.
No, no. You
Sir,
go
that
to the
is
seizure description, the slide which showed the seizure description. You said eyes went to the right, the face was deviated to the right, and the left limbs were tonic. Go back to that.
sir, that is actually right frontal, sir. Typing error.
நீ ஆரம்பத்துல left சொல்லிட்டு இருக்க.
Hmm.
Show the seizures. Head turn to right with
Sir,
eye deviation to right.
Sir, left focus seizures, sir. Right frontal localization, sir.
Followed by tonic posturing on left upper and lower limbs, lasting for 1 minute. And the head turned to the right with eye deviation to right. Okay. So
Yes,
you're
sir.
saying this is a right frontal seizure.
Yeah. Yes, sir. Yes, sir. Left focal seizures, right frontal onset, sir.
But then how does the head turn to the right?
First, sir, late head turn can be seen in frontal, sir. Frontal lobe
No,
seizure,
it
sir.
can be seen in frontal, but you are having a, from what you describe, correct me if I'm wrong, but this doesn't
Yes, sir.
exactly fit to one
Written.
particular focus.
Yeah,
No?
correct.
Okay, sir.
You
Yes,
don't
sir.
have
Okay, sir.
you don't have a video of the seizure.
No, sir. No, sir. We
Okay.
we were not able to get the
Okay,
videos.
okay, right, fine.
Yes.
Anyway, continue. So we do not know whether it was one single focus or multiple foci or focus
Yes, sir.
spreading to the other side. Okay, right, go ahead.
So why
Yes,
why
sir.
why do you think we are particular about this? Whether it's only a single for seizure type or whether there are multiple seizure types?
Sir, since in neuroregression syndromes in mitochondrial disorders, we can get multiple type of seizure episode like myoclonic, atonic, or focal seizures. And you have mentioned one possibility of tuberous sclerosis, sir. So tuberous sclerosis can have multiple foci, sir. So
No, all of them can have multiple seizure types, especially
okay,
with
sir.
neuroregression in the background.
Yes, sir.
And not only that, it can change over the course of the disease from one seizure type to another seizure type. It can change.
Okay, sir. Okay, sir.
Okay, fine.
Okay.
Proceed.
Okay. Yes, sir. Next slide. So still the structures involved would be pancerebellum and or its connections, along with bilateral corticospinal tract above C3, bilateral corticobulbar fibers, seizures probably, that is right frontal with secondary generalization, global developmental delay and intellectual disability which involves cortical and subcortical influx. Next.
No, wait a minute. So this is what is the go back. What is the order in which this happened? Do you want a chronology here, or see you're putting the last first, isn't it?
Yes, sir.
What came first?
Global developmental delay, intellectual disability should come first, sir, followed by
Ah.
pancerebellum, followed by corticospinal. Seizure should be last, sir. Yes, sir.
So does that help you? Does the nature of progress or the
Definitely.
evolution? Then
Yes, sir. It points to the etiology, sir. The structure should be in the reverse order, sir. Yes, sir.
Okay. Okay, right. Now
Next.
you proceed.
Yes, sir. Next. So this neuroimaging was done at 8 months of age in ICH Chigmore, showing T2 and axial T2 sections, which shows T2 hyperintense lesions involving the white matter predominantly. There is no diffusion restriction. The next is axial diffusion, which shows no diffusion restriction. Next. So this shows the diffuse white matter changes which is present along the white matter tracks. Next. Next. This shows the coronal T2 previous. This shows the coronal T2 and sagittal T1 section where T2 shows hyperintensity along the white matter tracts and T1 is iso-intense in the same corresponding white matter change area. So this was
what
done
is
at 8
happening to
months
the
of
corpus callosum?
thinning is there, sir. Corpus callosum thinning is there. The subsequent, we did it recently also, sir. Now we did
Thinning
an
only or widening? So
thinning. Like to commit it as thinning, sir. Widening, I'm not able to appreciate, sir.
okay.
Yes, sir. Now we have a recent MRI, sir. Next slide. This MRI is done in March 2025, showing
More extensive
persistence
lesions.
of yes, sir. Persistence. This is T2 and T2 flare axial, showing diffuse T2 flare hyperintensity is present on the white matter tract, which is when, as I told, it is more visible when compared to the 8 months of age onset. Next slide. So this is visible here, well visible here. So suggestive of a white matter disease. Next slide. Here, the similar, this is to show the side-by-side comparison of a T1 and a T2 sequence, which is very important in white matter disease because the white matter changes which is present in T2 is iso-intense on T1. Next slide. So we will
metachromatic leukodystrophy.
Sir, I will compare it side by side, sir, in the following slide, sir. Yes, sir. So approach to a patient with spastic ataxic syndrome. Since this is an early onset, we would like to consider RSAC, CTX, autosomal recessive HSP with cerebellar signs, Krabbe, vanishing white matter, which are Pol3, CoQ10A, VED, and SPAX group. So next slide. Since there is white matter change, we move more towards leukodystrophy. Next, here, autosomal, we would like to consider autosomal recessive spastic ataxic syndromes like RSACs, SPG7, CTX, and leukodystrophies, because here the patient has no family history. Next. Next. So, in our case, the possible modes of we already discussed. Next. So here I would like to quote an image from the literature. It shows difference between a hypomyelinating and a demyelinating leukodystrophy. The first A and B image shows T2 hyperintensities along the white matter tract with T1 showing isointensity. This is consistent with hypomyelinating leukodystrophy, which usually we have a prototype like Pelizaeus-Merzbacher-like disease. Whereas when the similar image shows a T2 hyperintensity with a T1 hypointensity, we consider a demyelinating leukodystrophy for which a prototype. Next slide.
Your voice
Sorry,
is
what
breaking.
was the last thing you said?
Your voice is breaking.
Yeah.
Yes, sir. The first image shows that the A and B
that is
shows
Pelizaeus-Merzbacher.
Yes, sir. Second image is vanishing white matter disease, where we consider demyelinating leukodystrophy, where T2 hyperintensity corresponding T1 will show hypodensity, sir.
Correct.
Yes,
hypointensity.
Hypointensity, sir. So we would like to compare the similar picture from literature to our patient. Here, the upper panel is from the literature. The lower two panel is from our patient, which shows T2 hyperintensity and T1 T1 normal intensity, that is isointensity. There is no hyperintensity in the T1 images shown in the lower panel. So we consider a hypomyelinating leukodystrophy in our case. Next. One other feature is that since Pelizaeus-Merzbacher-like disease is X-linked disease. Here, our patient is a girl. So, we consider Telesius Merzbacher-like diseases, PMLD spectrum of disorders. Since the patient PML usually has an anterior dominant leukodystrophy, whereas PMLD is usually diffuse hypomyelination, similar to our patient. Next. Next. In general, white matter disorders can be divided into two, acquired and inherited. Acquired, usually immune mediated, which causes destruction of normal myelin, whereas inherited can be divided into classical leukodystrophies and genetic leukodystrophy. Classical is usually the disorders which affect the CNS white matter with or without involvement of the peripheral nerve sheath myelin. Genetic leukoencephalopathies, in those CNS myelin is affected during a systemic metabolic disorder. Next. Latest accepted definition of leukodystrophy is a heritable disorder affecting the white matter of CNS without the involvement of PNS. There are two types of leukodystrophies, hypomyelinating and demyelinating. As we have told, hypomyelinating, in which hyperintensity of the white matter on T2 shows hypo, iso, or hyper on T1 is hypomyelinating. Whereas demyelinating, it should be definitely T2 hyperintensity with T1 hypointensity. That is demyelinating. So our patient probably has a hypomyelinating type of leukodystrophy. So considering the pattern of leukodystrophy, next slide.
1 minute, 1 minute. Show the previous slide.
This one, sir.
In both of these, what is the difference? Both shows, both in hypomyelinating leukodystrophy, you get T2 hyperintensity, mild hypo or isointense on T1. In demyelinating also, you show prominent T2 hyperintensity and hypointensity on T1 weighted sequence. So how does it differentiate?
Sir, one point is that if it is isointense or hyperintense, we can definitely tell it is hypomyelinating.
Yeah, only then, yes.
Only then, you sir. If it is hypointensity, we cannot differentiate between hypomyelinating and demyelinating, sir. But if it is isointense, we can definitely tell it is hypomyelinating, sir.
Okay. Only
in our patient, it is iso, sir. So
it is iso. See, both types of leukodystrophies are hyperintense on T2. Correct?
Yes, sir. Yes, sir.
The hypomyelinating ones are isointense on T1, whereas the demyelinating ones are hypointense on T1. Correct?
Yes, sir. Yes, sir. And hypomyelinating.
So that is how you are differentiating.
Yes, sir. Sir, in hypomyelinating, it can be hypo, iso, or hyper, sir. But in demyelinating, it is only hypo, sir.
So when they are both similar, then you won't be able to differentiate.
Sir, if it is hyper or iso, we will be able to differentiate, sir.
Correct, ma, but you said it can be hyper, iso, or hypo.
Yes, sir. But our patient has iso, sir.
Our patient has. Our patient has at this point in time. So suppose this patient had something similar to hypomyelinating, you will not be able to differentiate, no, whether it is hypo or hypomyelinating or demyelinating. You get the point.
Yes, sir.
So that another thing that I would like to point out is that differentiation also depends on the stage of the disease. It's not that any point in time that you do MRI in a patient with hypomyelinating leukodystrophy. For example, your prototype being Pelizaeus Merzbacher, it will always show hyper or iso. At various points in the disease, as the disease progresses, this pattern changes.
Yes, sir.
Okay, proceed.
Yes, sir. Yes, sir. The MRI taken at 8 months and even at 11 years, 12 years also showed T1 hypointensity itself, sir. Here, MRI patterns of hypomyelinating leukodystrophies can be diffuse hypomyelination pattern. Here, the patient has diffuse hypomyelination. So, PMN, PMLD, SOX10 associated, and NXK62 associated hypomyelinating type of leukodystrophies can be considered. Next. Next slide. So, depending on the mode of inheritance, I would like to consider an autosomal recessive mode of inheritance in this patient. So the disease spectrum of autosomal recessive type includes PMLD, fucosidosis, Pol3 leukodystrophy, 4H syndrome. Since she had dentition problem also, that has to be also considered, Cockney syndrome, and hypomyelination with brainstem, spinal cord involvement, and leg spasticity, DART2 mutation, and one other thing is hypomyelination with congenital cataracts. So these are the type of hypomyelinating leukodystrophies which can be considered in this patient. PML is not considered. PMLD is considered because PML is X-linked. Next. Here, the patient had nystagmus, and though we were not able to measure the head circumference, since it is hypomyelinating, similar way, PMD, PMLD, Soxton related, Pol R3, and 18q syndromes can be considered in this patient. And she also had spastic paraparesis, PMN, PMLD, late onset gangliosidosis can also be considered. Next. So this is side-by-side comparison of literature of a patient, of a 2-year-old male patient of PMLD, where he showed regression of milestones after attaining normal milestones in this patient showed. Here the patient had T2 hyperintensities involving the white matter of the corpus internal capsule, brainstem, corpus callosum, entire brainstem, and white matter, middle cerebellar peduncle, and there was cerebellar atrophy also. The down panel is of our patient showed hyperintensity involving the middle cerebellar peduncle with the white matter tracks in the brainstem. That is, this is the pons region, also shows some amount of hyperintensity, and here the patient also had a cerebellar atrophy. Next. Proceeding on with the genetic sequence, showed GJC2, that is gap junction mutation, which is pathogenic, suggestive of a Pelizaeus-Merzbacher-like disease. Next. 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 So here we have pure HSPs and HSP plus syndromes, where PMLD is an X-linked disorder. PMD, that is Pelizaeus-Merzbacher, is an X-linked disorder caused by mutations in PLP1 gene encoding the. Next slide, please. Next slide. Encoding the proteolipid protein, the main protein in CNS myelin, PLP1. Classic PMD affects boys. It's an X-linked and is characterized by nystagmus, impacts psychomotor development within the first year of life, followed by progressive ataxia, spasticity, chorioathetosis, and diffuse white matter changes on MRI, which is predominantly anterior dominant. Next. Whereas PMLD is clinically and neuroradiologically similar to classic PMD, but is not associated with PLP1 mutation. Here it is a recessive mutation in GJA12, which is renamed as GJC2, that is gap junction. Mainly connects in form gap junctions, which are intercellular channels that form link between the opposing cell membranes to permit the diffusion of ions and small molecules into and out of the CSF and intravascular space. Next. So here it is a HSP plus syndrome, where the patient here the patient is having a GJC2 mutation. So the only other example is PLP1, that is PMLD and PMD is a one type of HSP that is known to cause both leukodystrophies and spastic paraparesis type of presentation. So screening for GJC2 mutations should be considered for patients that present with complicated HSP phenotype and the presence of hypomyelinating leukoencephalopathic findings on MRI.
So that's all?
Yes, sir.
Good. Anybody else? Any comments, sir?
Thank you.
So why is it classified under if I understand you right, is it classified under HSP?
Yes, sir. Actually, it is SPG 44 is its nomenclature, sir. Actually, GJC2 mutation is seen in it's been classified under HSP SPG 44, sir. So we have a HSP complicated HSPs type. We have two mutations, that is GJC2 mutation and PLP1, that is Pelizaeus-Merzbacher and Pelizaeus-Merzbacher like disease, which shows hypomyelinating leukodystrophy and HSP phenotype. Are the only two mutations which will be seen, sir. So any patient, when we have a spastic HSP-like phenotype presenting with hypomyelinating leukodystrophy, we have to consider a possibility of GJC2 mutation and PLP1 mutation, sir.
No, that is the point that I was trying to make. Here, sir, Natarajan sir.
I am here. Yes, sir.
No, the point that I was trying to make is it is almost like putting the cart before the horse. Here, the predominant clinical features are global developmental delay and regression and seizures, and also having cerebellar and long track signs.
Pyramidal signs, yes, sir.
Pyramidal signs. In fact, the global developmental delay or whatever, that was the one which came earlier. So to me, it seems a sort of misnomer that they are classified under complicated HSPs, in which the long track signs and the cerebellar signs are the ones which are prominent, and the others are almost incidental.
Yes, sir. Correct. I am lost. I couldn't. I couldn't. It's difficult to comprehend. I was lost at all. For example, it was initially an initial insult was there. It was stationary, and then after 8 years or 10 years, showed progression. I mean, ultimately they showed what it is, but clinically trying to fit in is becoming difficult.
Yes, exactly. Yes, sir.
Excuse me, sir. I would like to add a point, sir.
Yeah, please.
Yes, sir. Actually, this child born with prolonged labor, but there probably that there was not a significant perinatal insult, sir. So that initial developmental delay probably can be taken as regression itself. Any patient with any babies without a significant perinatal insult, the baby found to have a developmental delay around significant that to head control around 5 years. Probably the leukodystrophy might have set in that earlier age itself. Could have, I mean, if I could have sent the genetic mutation that time itself, could have been diagnosed little early.
What is the life
there was
expectancy?
A very slow progression that it was not noted.
Yes, sir. Very slow progression. I mean, since there was also some history of prolonged labor, they might have thought it as HIEC.
What is the life expectancy in these subjects, these patients?
Sir, prolonged seizures and all is there, so it's limited. Exact age I'm not aware, and I'm not aware about the treatment options also.
Oh, okay.
Kritika,
No, there was a review article quite some time back, not recent, in I think NCNA or one of these periodic journals, which they had presented a compilation of all these kind of congenital, hereditary, metabolic, all these disorders with demyelination, hypomyelination changes, which begin with regression and seizures and go on to develop dementia in young adults. Okay. So there's a big list of that. I don't remember which year, but that was a very nice article.
Okay.
Is it only a leukodystrophy, or does it progress to involve the gray matter also, because the refractory seizures are there?
Seizures and all.
The gap junctions, the pathology is in the gap junction, sir. So that is the main reason for seizures, sir. That is the connections which is involved in subcortical. So it is mainly like similar to a focal cortical dysplasia type of thing. There is a mutation in the connection. So that is the main reason why the patient may develop seizures, sir. It is not the exact cortical pathology, sir.
But why doesn't it occur earlier then?
That is, I don't know, sir.
Anyway, thanks.
Thank you, ma. Thank you.
Thank you, sir.
Shall we go to the third case, sir?
Yes, sir. Please. Dr. Sangeeta, you are presenting the other case, no?
Yes, sir.
Go ahead, please.
Sir, are my slides visible, sir?
Yes, please.
Yes, yes.
Yes, sir. Good afternoon, sir. My presentation is regarding a lady with weakness and an unusual gait. This is about a 43-year-old female, right-handed individual, studied up to 8th standard, a homemaker, presented with complaints of difficulty in using both her upper limbs for the past 2 years and difficulty in using both her lower limbs for the past 1.5 years. On elaborating her presenting complaint, she was apparently normal 2 years back. Patient started noticing difficulty in using her arms. It was an insidious onset, slowly progressive. Right limb was more involved than the left, and she had difficulty in raising her arms for combing and shampooing her hair. Unable to lift the weight overhead, and she could not place or take the things from the overhead shelves. She had difficulty in bringing food to mouth, and she had difficulty in carrying things like the laundry clothes around her forearm. She had mild difficulty in buttoning and unbuttoning her blouse, opening the tightly closed bottles, locking keys, and sort food with ladle. All these difficulties are more on the right upper limb than the left. She will start her cooking activities in the right hand, and soon she will be aided by her left hand in all the course. For the past 1 year, she has difficulties in using her left upper limb also, proximal more than distal. History of difficulty in using her both lower limbs for the past 1.5 years. Within 6 months of her upper limb difficulty, she started having difficulty in using her lower limb in the form of mild difficulty in upsquatting. She needed one hand support to raise from the squatting. She had difficulty in climbing upstairs and downstairs. History of minimal difficulty in insinuating her foot into the slippers and gripping is present. No history of any aware or unaware slippage of the slippers. No history of tripping over small obstacles or an increased tendency to repeatedly sprain her ankles. No history of foot drop or slapping gait. History of inability to stand on the toes while trying to reach out for the objects that were present over shelf. No history of difficulty in lifting the neck from the pillow upon awakening. No history of head rocking forward or backward while riding as a passenger. No history of chin falling on the chest when the patient is stooping or bending forward, or there was no history of head drop. No history of difficulty in turning over in bed. No difficulty in maintaining the erect posture. No history of any orthopnea, exertional dyspnea. No history of drooping of eyelids or backward tilting of the neck to look ahead or upward. No history of difficulty in moving the eyeballs. No history of double vision. There was no history of difficulty in drinking through straw, or no difficulty in whistling or blowing up the balloons. No history of drooling or retaining saliva. No history of sleeping with the eyes open or any irritation due to soap water while bathing. No history of abnormal smile or reduced face expression. No history of difficulty in swallowing, nasal registration, choking spells, aspiration of liquids, nasal or hoarse quality of voice. No history of difficulty in coughing. There was no history of thinning of limbs, no history of fasciculations, no history of stiffness or foulness of the limbs, no history of diurnal variation in her weakness, no history of fatigability, there was no chewing difficulty, no history of muscle pain while doing her course. History of occasional cramps in bilateral calf muscles was present. It gets relieved in 5 minutes upon stretching. No history of relationship of weakness to fasting state or fed state after or before exercise. No history of difficulty in releasing her grip or worsening of weakness in the cold. No history of abdominal hernias. No history of any worsening weakness during periods of stress like fever. No history of passing cola-colored urine after strenuous exercise. No history of chest pain or palpitation. History of mild hearing deficit in the left ear present. No history of toxin exposure, thyroid illness, skin lesions, joint pains, recurrent fever, or any native medicine intake. No history of ICU admissions or ventilator care. No history of malignancy, chemotherapy, or statin use. No history of any sensory complaints. No history of unsteadiness in dark or cotton wool sense in feet. No history of bladder bowel complaints. No history suggestive of cerebellar or higher mental function deficit. No history of involuntary movement, bradykinesia, rigidity, and falls. No history suggestive of abnormal sweating or features of orthostatic hypotension. So coming to the past history, she is no similar illness in the past. She is a recently detected hypertensive and she has impaired glucose tolerance. Family history, she was born fifth to non-consanguineously married parents by normal vaginal delivery. There was no delay in her developmental milestones and there was no similar illness in the family. Personal history, she is married and has two teenagers who were born to her by normal vaginal delivery, takes mixed diet, studied up to 8th standard, and she is a homemaker and occasionally goes for nearby agricultural work. Treatment history, presently she is on single antihypertensive drug and multivitamin supplements. So summary, 43-year-old female with 2 years history of insidious onset, slowly progressive, asymmetric weakness involving right more than the left, upper limb more than the lower limb, proximal more than distal, pure motor element weakness with no ocular, facial, bulbar, respiratory muscle weakness and fatigability, with no sensory, higher mental function, cerebellar, extrapyramidal and autonomic symptoms. With these possibilities in the neuroaxis, since it is a pure motor element syndrome, our first thought was the structure involved could be muscle. The favorable points for muscle in this patient was it's a pure motor element syndrome, proximal more than distal. There was no history of thinning, no history of fasciculation. Weakness was more than wasting, no history of flaileness or stiffness. The less favorable point here is it was a asymmetric weakness. Right was more involved than the left. Our second possibility was anterior Hansel. Here also the favorable points for anterior Hansel is again pure motor element, proximal more than distal, no stiffness or flaileness. Less favorable points were there was no obvious wasting, there was no fasciculations, and the pattern of wasting more than weakness is not seen here. And the remote possibility is motor root. Again, because of pure motor element type weakness with proximal more than distal. The less favorable points were asymmetricity and there was no fasciculations. So in the muscle axis, our possible thinking were since the patient had mainly asymmetric weakness, upper limb involvement more than the lower limb, first possibility what we thought was FSHD. Again, the favorable points were asymmetric involvement, periscapular involvement, there was absence of ptosis and dysphagia. Patient had a history of hearing loss. The less favorable points were there was no family history and there is no facial weakness. The second possibility was Emery-Dreifuss muscular dystrophy because upper limbs more involved scapuloperoneal type of weakness. Less favorable points were there were no history suggestive of contractures. Again, there was no family history and there was no cardiac complaint, which will be mostly seen in Emery-Dreifuss muscular dystrophies. The third possibility were scapuloperoneal dystrophies. Again, because of shoulder muscle weakness, and there was no facial weakness. But mostly in scapuloperoneal type of dystrophy, the legs will be involved first. The fourth possibility was myofibrillar myopathy. This myofibrillar myopathy has a varied presentations. The points for in this patient is adult onset weakness. It can have FSHD or scapuloperoneal type of weakness. Less favorable were mostly myofibrillar myopathies are of distal weakness, predominantly distal weakness involving either arms or the legs. It is not specifically upper arms. And fifth possibility was metabolic myopathies like glycogen storage disorders or lipid storage disorders. Again, considering her age of onset, usually adult onset glycogen storage disease and lipid storage disease have their presentation in the third to fourth decade. Proximal weakness was favorable and history of some occasional cramps was there. So that was favorable here. The less favorable points were against was no respiratory muscle weakness. There was no history of any exercise intolerance. There was no fatigability or second wind phenomena. The other possibility was inflammatory myopathies like polymyositis, especially. Again, age of onset in polymyositis, adult onset, female preponderance, predominant proximal. But against were asymmetricity, there were no constitutional symptoms, and there was no history of dysphagia. In the anterior console possibility, our thought was possibility of adult onset SMA and scapuloperineal variant SMA. Adult onset SMA, the favorable finds were again pure motor, proximal more than distal. Less favorable were no atrophy, no fasciculations, no early involvement of quadriceps, because in adult onset SMA, quadriceps is said to be first involved. Scapuloperoneal variant of SMA again, pure motor, proximal more than distal was favorable. Less favorable was against no atrophy or fasciculations. The motor route, possibility of pure motor CADP can be thought of because there was no family history and the weakness was proximal more than distal. Again, asymmetricity, no wasting and no relapsing remitting course was not favorable for pure motor CADP. Shall I proceed, sir?
Anybody else? Other PGs, any additions, any other thoughts? No? Okay, I think proceed.
Yes, sir. General examination was normal, conscious oriented. She was cooperative for examination. There was no pallor, icterus, clubbing cyanosis, lymphadenopathy, or pedal edema, no neurocutaneous markers. Her vitals were stable. Her cranial nerve examination was normal. And coming to the spinomotor examination, upon observation, patient had bilateral deltoid wasting, right more than left. Bilateral rhomboid swinging was present. Bilateral supinator contracture was present. Bilateral thinning of the legs below the knee present. And bilateral EDB was preserved. This was the picture of the patient showing generally on the outlook, her upper body torso appears hypertrophied when compared to her lower portion, and only there was significant deltoid wasting was noted. Bilaterally, right side, this acromion process is more visible, and this dimple we can see over the deltoid. Other than that, there was no prominent wasting, and in fact, it appears hypertrophied. When I asked to keep the hand in this position, since she had asymmetrical weakness, left she was able to do with a little difficulty, and right she could not keep in that position. So with aid, I helped her keeping the right hand in this position, and upon doing that, this scapular border appeared prominent, and possibility of rhomboid swinging was there. But when the patient outstretched her arms and did a test for serratus anterior muscle, there was no prominence of the scapula. So there was no serratus anterior winging. So coming to the bulk, there was not of much discrepancy. Even though she was having asymmetrical weakness, the bulk measurement didn't show much of discrepancy. Tone was normal in both the upper limb and the lower limb. Coming to the power examination, the worst power was on the right side. Patient shoulder abduction was weak. She had only 3. She cannot. She can move against resistance, and other weakness were in the shoulder flexion group and external rotation. So in the shoulder region, patient had much difficulty in abduction and also in flexion of the shoulder and the external rotation of the shoulder. In the elbow, patient had severe flexion weakness. Whereas on the right side, yes, sir.
So how is it that you say that the tone is normal with so much of weakness,
Yes,
grade
sir,
3 power?
Yes, sir. Yes, sir,
And you
but the
said there is some
tone,
thinning of the lower limbs. So how can your tone be normal in such a situation?
yes, sir,
Hmm?
but we expected for a reduced tone only, sir, but the patient had normal tone, sir.
That is
There was
clinically not
only,
feasible, no? It's not acceptable. With so much, you
yes,
said
sir.
the thinning of legs and there is so much of weakness in the upper limbs. So anyway,
Sir,
proceed.
possibility this selectivity, sir, even though she is not able to lift the arm, it's mainly abduction weakness, sir. So a
So
preferable
you
muscle
should check tone
involvement.
at all the joints. Should check tone individually, no? At shoulder, what is the tone? And
Yes, sir.
elbow, what is the
It
tone?
was
At the wrist, what is the tone?
it was normal only, sir.
Should move
Tone
muscles
was
individually
normal
and
in
check.
both upper limb and lower limb, sir.
Hmm. Okay, proceed.
Yes, sir. In the wrist, there was 4 minus, extension power was 4 minus, sir. Bilateral flexion, it was 4 plus. Hand grip was normal. Finger flexors normal, sir. Finger extensors are mild weak, sir. Neck muscle power examination, flexion was normal and extension was weak. Trunk muscle power, flexion and extension both were normal. Beaver's sign was absent. Coming to the lower limb examination, her hip flexion was 4 plus bilaterally, extension was 4 minus bilaterally, adduction and abduction was 4 plus, and internal rotation and external rotation were 4 plus bilaterally. In the knee joint again, flexion and extension both were 4 plus. In the ankle joint, dorsiflexion and plantar flexion both were 4 minus, and the toe grip was normal, and toe flexion and extension was normal. Coming to the reflexes, all the reflexes were present. Biceps, triceps, supinator, and knee jerk were 2 plus and ankle 1 plus. Superficial reflexes were present and plantar bilaterally it was flexor. Sensory system examination, pain, temperature, vibration, joint positions intact bilaterally. Romberg's test was negative. Cortical sensation was intact and extrapyramidal system examination was normal. Cerebellum examination also, both in the upper limb and the lower limb normal. When coming to the gait, patient had a waddling gait with hyperlordosis. There was no autonomic system involvement and spine and cranium was normal. Coming to the gait of the patient, when we see the upper torso, her shoulder appears to be directed backwards and the arm is facing backwards, and also the thumb, instead of facing in the front, it is also showing in the backward position. So the shoulder girdle weakness is very evident from her gait. And because of that shoulder weakness, she is pushing her trunk and there is a protuberant abdomen also. And we can appreciate waddling also in her gait. Other system examination was normal. So after examination, the summary is 43-year-old female with 2 years history of insidious onset, slowly progressive, pure motor element weakness, asymmetric right more than left, upper limb more than lower limb, proximal more than distal, with selectivity of muscle involvement and intact reflexes, with no ocular, facial, bulbar, respiratory muscle weakness and fatigability, with no sensory, higher mental function, cerebellar, extrapyramidal and autonomic symptoms. Again, after examination, our first possibility is muscle because of proximal more than distal involvement, no fasciculations, intact reflexes, and preserved EDB. The first possibility was FSHD, the same asymmetric periscapular involvement, absence of ptosis dysphagia, and presence of hearing loss. Unfavorable points were no family history, no facial weakness. There was no sparing of deltoid. Usually in FSHD, we say deltoid sparing will be there. But here there was no sparing of the deltoid. In fact, deltoid was wasted. The second possibility of scapuloperoneal type myopathy, The scapuloperoneal type myopathy has myofibrillar myopathy and metabolic myopathy under these. Again, adult onset scapuloperoneal type weakness, proximal more than distal, were the points favorable for both. Unfavorable were in myofibrillar myopathy, as already said, usually legs will be involved, distal weakness will be more prominent. For metabolic myopathies, there is no history of exercise intolerance, fatigability, or family history. In the anterior console, possibility of scapuloperoneal type SMA can be considered even after examination because of the proximal more than distal involvement and asymmetricity, but unlikely where there was no fasciculation throughout the examination, the reflexes were intact and the EDB was preserved. Shall I proceed, sir?
So ultimately, what is your first diagnosis? FSHD, is it?
Yes, sir. The patient's main presentation was asymmetric scapuloperoneal type of weakness, sir. First possibility of FSH. Yes, sir. First possibility we got
proceed.
in terms of FSHD only, sir. But against
Hmm.
FSHD is there was no facial involvement at all, sir. And usually we see in there will be deltoid sparing in FSHD, but in our patient the deltoid was the main muscle that was involved, sir. Second possibility of scapuloperoneal type myopathy. This scapuloperoneal weakness can be both myogenic and neurogenic, sir. Differentiation between myogenic and neurogenic pattern of scapuloperoneal weakness is actually difficult, and there were no points favoring either myogenic or neurogenic, sir. So further we have to proceed with other investigations, sir. And third possibility, proximal weakness, we considered this in that
Why do you
scapuloperoneal
keep
type.
metabolic myopathy here? I mean, you don't have any history which is
Yes,
even
sir.
remotely
History
suggestive of a
since
metabolic problem here.
sir, actually, I searched in terms of when I was presenting this case, I searched in terms of scapuloperoneal type of myopathy, sir.
Okay.
Scapuloperoneal type of myopathy and scapuloperoneal type of anterior console disorder, sir. In that scapuloperoneal type of myopathies, possibility of FSHD, Emery-Dreifuss, myofibrillar myopathies, inflammatory myopathy like polymyositis, and this metabolic myopathy they have given, sir. So I took it as
But
a DD.
Sangeeta,
No,
Yes, sir.
Sangeeta, why
no,
not
that.
Yes, sir.
LGMD? Why not LGMD?
LGMD mostly, yes, sir. Possibilities are there, sir.
You
Like
have not
sarco.
discussed that. You have not included in your differential. Why have
Again,
you
age
excluded
of
LGMD?
present, yes, sir. Yes, sir. Scapuloperoneal type of weakness is uh, was not more towards LGMD, sir. In LGMD, sarcoglycanopathies can have the scapuloperoneal type of weakness, sir. But that too, they have given lower limb involvement will be more than upper limb, sir. So
See,
to
but
shrink the
diseases don't
DDs,
follow textbooks.
yes, sir, sure, sir,
So
yes,
you
sir.
should keep that as a differential,
That
isn't it?
also, yes, sir, we had, sir,
Yeah.
yes, sir,
And
yes,
another
sir,
point, see, clinically in favor of muscle is your preserved EDB after so many years of disease.
yes, sir,
That
yes,
still
sir,
points to a probable myopathic or a myogenic etiology here,
yes,
rather
sir,
than. And that preserved thing is not seen in inflammatory myopathies. It is specific to dystrophies, as far as I know. So
okay,
correct
sir,
me if I am wrong. So
Yes, sir.
still
yes,
you
sir,
should lean towards dystrophy only. But again, as you said, the phenotype doesn't fit in with a typical FSHD. So I don't know. I would not put that at the top of the list. Like sir
yes,
said,
sir,
LGMD, probably sarcoglycanopathies, and
yes, sir,
the variants thereof.
Yeah,
Those
we'll have
yes,
to
things
sir,
go
should be
for the
considered.
genetic studies. Only genetic
yes, sir,
study will come. Okay.
yes.
Yeah.
Shall I proceed, sir?
Yeah, please.
Yeah, please proceed.
Her routine investigations, complete blood count was normal, sir. Sugar, urea, normal, sir. Her ESR was 10 millimeters 10 millimeters per hour, and CRP negative. Her CPK was 1018, sir. TFT normal, HIV, HBsAg, HCV antibody was negative. Pure tone audiometry revealed bilateral sensory neural hearing loss. Echo was normal. Ultrasound abdomen showed mild hepatomegaly with fatty liver. Her
Okay.
lipid profile showed increased amount of cholesterol, sir. Total cholesterol was 248, triglyceride was 278, and there was minimal elevation of the SGOT, SGPT, accounting to about 116 and 136, and there was also minimal elevation of gamma GT. So we proceeded with NCS and EMG studies. NCS was normal. EMG, there was no spontaneous activity, and a small amplitude, short duration polyphasic MUAPs were obtained with complete interference pattern. Again, that was more in favor of a muscle disease, sir. Then we went ahead with the biopsy, sir. Biopsy, again, the dilemma continued. There they gave us neurogenic and subtle myopathic changes of the left delta. We gave the sample of left deltoid, sir. Neurogenic and subtle myopathic changes they reported. Further, so CPK was mildly elevated. A scapuloperoneal type of asymmetric weakness, upper limb more involved than the lower limb. EDB preserved. We did NCS EMG. EMG was favorable towards a myopathic process. Biopsy was not concluding as myopathy. So we had in our basket we had next MRI. So we proceeded with the MRI of the right shoulder and screening of the left shoulder, sir. In that there were complete or near complete fatty replacement of the supraspinatus, infraspinatus, and the deltoid, sir. This is the axial and the coronal sections. I will give a here if we see, this is the spine of the scapula, and there is a complete or near complete replacement of the supraspinatus, infraspinatus, and also the deltoid and teres minor, which actually correlated with our weakness pattern also. Patient had our delta shoulder abduction, external rotation weakness, and flexion weakness, sir. So
Right.
the MRI shoulder was reported as complete fatty replacement of the right supraspinatus, infraspinatus, and the teres minor muscles. Near complete replacement of the right deltoid muscles, sparing a few anterior and posterior fibers, and internally rotated right humerus with intact subscapularis muscle and its tendon. This was the report, sir. Again,
No, you did.
yes,
Excuse
sir.
me. You did MRI of the left shoulder also.
Yes, sir.
Or
That is
one
mentioned
side.
here, sir. The left shoulder joint scapular humerus region, partial or near complete fatty replacement of the left supraspinatus, infraspinatus, and teres minor. Again, the same, sir. Partial
What
fatty
about the
replacement.
deltoid?
Partial fatty replacement of the left deltoid also they have mentioned, sir. So deltoid was also involved, sir.
No,
Near
deltoid is
complete
involved.
replacement of right. Yes, sir.
Correct. No, see, but the thing is, there is an obvious conflict between your MRI and your histopathology, isn't it?
Yes, sir. Yes, sir. That actually we have requested a second opinion of the histopathology report, sir, considering the MRI and other things, sir.
No,
What
but
They
you
have
about
see,
the
told
there.
that
genetic
they will
study,
proceed.
ma? What
Sir?
about the genetic study?
Sir, I will. Yes, sir. I am coming, sir. Sir, with this pattern of usually muscle MRI are done only for the mainly for the lower limb, sir. So the upper limb muscle involvement pattern in MRI, the literature was very minimal. In that, I could pick up FSHD, EDMD, and this neutral lipid storage disease was myopathy, sir. Here, commonly involved muscles, if we see in the trapezius, mainly in the FSHD, mainly the trapezius, serratus anterior, pec major will be involved, sir. Usually spared will be deltoid, supra, and infraspinatus, which was not in our case. Again, in EDMD, teres major, subscapularis, supra, and infraspinatus will be involved, whereas in our case, they clearly gave us subscapularis spared, and here also, whereas in EDMD, deltoid can be spared. And to our surprise, we saw that this typical pattern, supraspinatus, infraspinatus, teres minor, and deltoid involvement and sparing of the subscapularis can occur with a neutral lipid storage disease with myopathy. So, upon seeing the literature into that, since we didn't have a DD of this in our basket, we had only FSHD and EDMD. Then we saw into the literature of the neutral lipid storage disease with myopathy. It is actually a rare autosomal recessive genetic disorder characterized by the abnormal accumulation of triglyceride in the form of large lipid droplet in various tissues throughout the body. There will be an asymmetric scapuloperoneal type of weakness. But in many of the literature, the scapuloperoneal type weakness under this heading, nowhere it was given, sir. Only when we looked into the specific disease, it was mentioned that patient will be typically having an asymmetric scapuloperoneal type of weakness. And another thing we found was there can be Jordan's anomaly. It is a distinctive and highly reliable diagnostic marker. It is the presence of numerous lipid-containing vacuoles in the cytoplasm of the WBCs, which can be observed in a standard peripheral blood smear. So, since we had all other things done, we thought of doing, since it is a peripheral blood smear study with HIE staining only, we thought of proceeding with whether the patient may have this Jordan's anomaly. So, to our surprise, in our patient, we found these lipid droplets inside the WBC, sir, which is called as Jordan's anomaly. They are well-defined lipid vacuoles seen only within the WBC, and sometimes artifact can occur, but usually those droplets will be peripheral, one or two, and the margins will not be this much regular. So, as per the pathologist report, this lipid droplets were seen in all the WBCs which were seen in the patient's peripheral smear slides, sir. So then the genetic report also came as homozygous variant of uncertain significance detected. That is, the mutated gene is patatin-like phospholipase A2, PNPLA2, which is an autosomal recessive. Here the patient had homozygosity and which can lead on to neutral lipid storage disease with myopathy. Since even though it is a variant of uncertain significance, the typical MRI picture involving the deltoid supraspinatus, infraspinatus, teres minor, and sparing the subscapularis, and patient having a fatty liver, hepatomegaly, and mild elevation of cholesterol levels, and we were able to pick up Jordan's anomaly in her peripheral smear. The possibility of neutral lipid storage disease with myopathy was concluded, sir.
Right. So, is there any treatment for this?
Yes, sir. This is actually a storage disorder, sir. Triacyl glycerol cannot be converted to diacyl glycerol because of the adipose triglyceride lipase deficiency, sir. Sir, shall I read these slides, theory 2 or 3, sir? Or
Yeah,
this is the.
You can tell us in brief.
Yes, sir.
Because I think we are running over
Yes, sir.
time.
This. Yes, sir. Usually, lipid metabolism defect, we will see carnitine palmitoyl transferase and primary carnitine deficiency, sir. This thing, neutral lipid storage disease, is another entity within this lipid storage disorder, sir, which can present as either lipid storage disease with myopathy or lipid storage disease with ichthyosis. Only the gene variation will be there, sir. In NLS-DM, there is a genetic mutation in the gene PNPLA2, that is patatin-like phospholipase A2, which codes for adipose triglyceride lipase, which is essential for conversion of triacyl glycerol to diacyl glycerol. Because of this defect, patient will be having excess triglyceride accumulation in the skeletal muscle, cardiac muscle, hepatic, pancreas. It is a multi-system disorder, sir. So far, only about 47 patients were genetically proven with this NLS-DM, and this disease was first noted in 2007, sir. And due to the rarity of this disease, additional cases are needed in order to more fully characterize the clinical presentation and correlate the genotype with phenotype to aid in a more timely and accurate diagnosis. And as I said, it is due to the defect in PNPLA2, which codes for this adipose triglyceride lipase. Defect in this will lead to accumulation of the lipid droplets. The clinical manifestation.
Right. No, what I asked was, is there any? No. All
Yes,
that is
sir.
fine. What I was asking was, is there any treatment for this?
Yes, sir. Treatment choices they have given, sir. not since it is only a cohort of 45 patients all over the world, they are trying with some remedies like this improvement of myopathic symptom using bezafibrate, sir. There's an alpha PPR gamma receptor agonist have been published, and alpha adrenergic stimulation using clenbuterol is also on the go, sir. And what
But it
we
says
have
beta
advised,
adrenergic here.
yes, sir.
It's beta
That
adrenergic.
actually that improves the muscle anabolism they have given, sir.
Okay.
Usually, even in FSHD also they are trying like that they have given, sir. For our patient, actually, we have advised her since it is because of triglyceride accumulation, low fat diet, and this thing is mainly medium chain triglyceride diet. That is using coconut oil can be tried because it directly has diacylglycerol. There is no need to convert from triacylglycerol to diacylglycerol. So this adipose triglyceride lipase will not be in the scene, sir. So it is better to use medium chain triglyceride diet. There are studies which quoted that this was helpful in some, and whereas in others, even though it is helpful in fatty liver and pancreas fatty accumulation, in myopathy it is not of much help, sir. But anyway, the studies are undergoing, sir. Important role is played by physical exercise by activation of alternative way of lipid metabolism. So to promote physical exercise and motor rehabilitation, sir. And this was in 1953. This Jordan's anomaly was first published by Dr. Jordan, who in 1948 examined the two brothers with proximal weakness and hepatomegaly. Incidentally, he looked into their peripheral smear and noted these lipid droplets within the WBC, and hence it was named as Jordan's bodies, and which is mainly specific in lipid storage disorders, sir. So the take-home message will be, in any adult onset, slowly progressive, asymmetrical, especially right more than left, proximal upper limb weakness, consider this neutral lipid storage disease with myopathy as one of the DD, because fatigability, exercise intolerance, myoglobinuria, all of things need not be present in this storage disorder, sir. And we can proceed with simple peripheral smear test to look for this Jordan's anomaly. And since there are some valuable treatment options, we should consider this entity and follows. That is it, sir. Thank you, sir.
Thank you very much. Yes.
Yes, sir.
Very good. No, I must congratulate this team for following it up and doing such a nice workup in this patient. Especially that simple peripheral smear with those vacuoles were very impressive. Very nice.
Yes, sir. Yes, sir. That was the first time we are also seeing, sir. Yes, sir.
Yeah, first time anybody is seeing. Yes.
Yeah, all of us.
But at least you got the idea to look for that and see that. Yes.
Because the literature told it is a diagnostic marker, sir, and it was a so simple test we proceeded with that, sir.
Okay.
Yes, sir.
Thank you.
Thank you, sir.
Thank you very much. Thank you.
Yes.
Thank you, Professor Shankar Ganesh. Thank you, Balaji. Thank you, Hari. And thank you, presenters. Now it's up to Professor Vasudevan.
Sir, நீங்களே conclude பண்ணிடுங்க. Thank you. Thanks one and all for a wonderful presentation, all of you.
And discussion. Thank you, Professor Alagesan. Thank you, Professor Vasudevan, for all your inputs. And thanks, sunpharma, as usual, for arranging this meeting. Thank you, sirs.
Thank you, sir. Have a good day.
Same to all of you. Sunpharma, are you there?
Yes, sir. Yes, sir.
Thank you so much. Thank you very much.
Yeah, thank you, sir.
Can we leave now?
Yes, sir. Yes, sir.
We have extended the time by half an hour.
No issues, sir. No issues.
Okay. Thank you. Thank you so much. Thank you. Thank you, presenters. Thank you.